like I said, the awake sedation, the sedation technique is mostly preferred for the patient, because in that case, the complication that can happen because of the general anesthesia is less. But another technique that we can do is the general anesthesia.
No, I understand. This is general. In that case, do you think we need to change the title of the paper? Neuro anesthesia perspective on awake craniotomy. I mean, that's a query. My curiosity.
Sir, actually, yeah,
about
sir,
it. Am I correct in pointing out, Ashok?
Yes, sir. Actually, sir, while reading the other papers also, I found it out that awake craniotomy is actually a misnomer. Even if we use sedations, the level of sedations will vary. If supposedly we have given a good regional block, then also the patient is feeling pain, then we will have to deepen the block. So, like at the point when the surgeon is opening the scalp and doing the dissection, which are the painful layers of the which is the painful part of the procedure, then the patient has to be sedated. But after the opening has been done and the brain has been exposed and the surgeon is working on the brain is an insensitive part of the pain, then we can actually lower down the sedation or stop the anesthesia if we are giving any, and then we can tell the patient to perform the motor activities. So awake is actually a misnomer, sir. The patient.
But in the picture, it has been shown that a patient is playing.
Yes, sir. At that time, we have made the patients awake. Sir, we have reduced the sedation.
So that is why. Okay, fine. Thank you. We have explained it. I mean, I'm
playing with the consciousness of the
yes, sir.
So you actually anesthetists take the decision according to the situation, right?
Yes, completely.
Normally what we do is, we select the patient according to that. If the patient is for epilepsy surgery or where there is unlikely to have severe bleeding episodes or complications, then you go for the full only sedation. If it is you are going to operate on an AVM near the eloquent area, then you go for dual mode. Then you can change interchangeably. What we mean by awake here is, we have to do some motor or auditory commands to the patient. And he should be able to hear or appreciate that command. That state of consciousness is called awake here. Not fully awake, he will not be able to talk.
No, sir.
I think all types of surgeries cannot be done under this, like meningioma and all, where there will be signs of bleeding. Any duration, any limitation of duration? Sometimes neurosurgeries, they take so many long times.
Sir, prolonged, if it is a prolonged surgery, then general anesthesia will be a better option. General anesthesia will always be better.
So if you are going for a general anesthesia procedure for a surgery in a eloquent area, what are the other modalities you will check for monitoring the patient? Patient in general anesthesia in an eloquent area, what modalities of monitoring you will do?
If the patient is a general anesthesia.
Yes.
Sir, ETCO2 monitoring will come with general anesthesia. Again, ventilate all the respiratory monitoring of the patient. As the patient is on ventilator, we have to monitor the respiratory mechanics of the patient. Plus, other monitoring, sir, during the awake phase, when we are about to make the patient awake, first important thing is the patient can't buck. Because if the patient bucks, the ICP will rise, it will create a problem for the surgeon and for us as well. It will lead to vomiting as well. And another thing is, since the patient will come out from a general anesthesia, the patient will be disoriented at that time. So we will have to be careful with that. And again, intubating the patient after the awake phase is over or after we have done the testing is also a challenge. So we'll have to be prepared for that.
Excuse me, sir.
No.
Excuse me, sir. Can you go to next topic, sir? Getting late.
Now here one point is that suppose you are doing in a general anesthesia patient on operating in eloquent area. All general monitoring is there, but specifically we have to have, many people have this EEG and EMG monitoring. That will indicate which motor area you are reaching or not. Okay. functional monitoring of the brain.
Okay, thank you, Dr. Thomas. Moving forward, I want to invite Dr. Vishnu, DMB Emergency Medicine, to speak about approach to polytrauma emergency.
Good evening, everyone. I'm Dr. Vishnu, second year emergency medicine resident in Apollo Hospital. Today I will give a brief discussion about approach to polytrauma in our emergency. So we just start with a case. It's a 24-year-old male with a motorbike accident with a tractor. So on arrival to ED, he was wearing a helmet with obvious facial injuries and unresponsive, tolerating to oropharyngeal airway, vomiters present in mass, noisy breathing is there, respiratory rate is 40, with heart rate 140 and BP 80-60. So how will we approach a patient who came with a motor traffic accident in our emergency? So we usually follow as a standardized protocol ATLS. So ATLS is Advanced Trauma Life Support. It was actually developed in 1976 after a plane crash in which Dr. James K. Steiner crashed in Nebraska. At that time, his wife instantly killed and 3 children were sustained critical injuries. From that, he initially triage in the field, flagged down a car to transport the nearest hospital, but the appropriate setups were not there in the third hospital. So from it was a starting of the ATLS, and it was being conducted nationally by American College of Surgeons, and the course is revised every 4th year. So in trauma, there is a trimodal distribution where you can see the immediate death within few hours or within minutes, then and second category of the death within 48 hours, and after that within 2 to 4 weeks. Immediate death we can see in lacerations of the brain, in any brainstem injury, in an aorta or heart injuries. Again, the second type within 48 hours we can see in epidural, subdural hematomas, then pneumothorax, long bone fractures and abdominal injuries. And following the third type, within 2 weeks to 4 weeks is actually a critical care peak with sepsis and multi-organ failure. So if a patient came in our emergency with a road traffic accident, we will follow with as an initial assessment, preparation, triage, then a primary survey will be there as per ABCD approach that we'll be discussing the next slide. Then it's adjuncts to a primary survey, consideration for the need for the patient transfer. There is a secondary survey from head to toe evaluation and with a proper history. After that, there will be adjuncts to the secondary survey, and then we will give re-evaluation and a definitive care. On preparation, there will be mainly 2 steps, the pre-hospital and the hospital phase. Pre-hospital phase is when the patient from the area of incident, the patient will be shifted to our hospital. So at that time, what are the things that will be given? So there will be immobilization of the proper immobilization of the patient would be the, if required, C-spine collar can be applied from there only. Then if required oxygen or any bleeding is there, we can stop that bleeding by some methods. Then after that, from the pre-hospital phase, in hospital area, we can sometimes, we will get information about the incident and how many patients are coming to our hospital. So in hospital phase, we can make a proper trauma team with suitable surgeons, ortho team and everything, so we can prepare a trauma team for that. So in triage, it involves the sorting of patient based on the resources. Suppose the patient from the preparedness phase, from the pre-hospital phase, it comes to the hospital phase, and we see sometimes we have a lot of casualties. There it is maybe multiple casualties and mass casualties. So in that time, if number of trauma is higher, so we have to triage the patient. So triage involves the sorting of patient based on the resources required for treatment and the resources that are actually available. So we have three categories: red category, yellow and green category. Where the red category are immediate one, we have to attend that patient within 2 minutes. Then yellow category, it's also having severe injury, you have to attend the patient for within 10 minutes, and green category within 30 minutes. Black category refers to disease months. So the primary survey, it includes mainly ABCD approach. So patient came with in an emergency, then we have the primary survey where airway, breathing, circulation, disability and exposure have to be checked. So airway, first we have to look for the airway maintenance with restriction of cervical spine motion. So how will you check the airway? In initial second, if the patient is able to talk, that means the airway is patterned. Otherwise, we will look for any gurgling sound, any patient is agitated, any foreign body is there, any maxillofacial fracture, and tracheal or laryngeal fracture is there. So these have to be done within 10-second assessment of an airway maintenance. There are two methods, so that if you see the patient is struggling for or snoring or the airway is not patterned, we can do, there are two methods, actually head tilt chin lift maneuver and jaw thrust maneuver. But as the head tilt chin lift maneuver cannot be applied in a traumatic patient unless the cervical spine injury has been ruled out. So better one is jaw thrust maneuver. And another one is manual inline stabilization. If the patient with head injury have come, suppose, then we have the airway is not patterned, we have to intubate the patient. So better using by this cervical immobility can be done by two methods, by using a manual inline stabilization or using a hard collar. But unless the C-spine is ruled out, we can use hard collar method if we do not rule out the C-spine injury. So in manual inline stabilization, we can give two approach, either from the behind of the patient and from in front of the patient. It is performed by an assisting during survey airway management to maintain a neutral position and movement of the head and neck by either crouching beside the intubator with hands placed on the patient's mastoid process, that's from the behind, and standing beside the patient in front of the intubator with hands placed on the side of the patient's head and forearms. Traction may not be applied. If airway is not managed, we can use of oral and nasal airway can be done, but nasal airway is not at all preferred unless the base of skull fracture is being ruled out. If the patient vomits, then we have to log roll the patient, and for pharyngeal suction have to be done. If there is if you think the patient needs a definite airway, if the patient has less GCS of less than 8, then we have to endotube the patient. Endotracheal intubation have to be done. Otherwise, in a difficult airway situation where your endotracheal intubation has been failed, you can do another emergency access to trachea by cricothyrotomy and formal tracheostomy. So next airway, if you secure the airway, you come to the next survey of breathing. So breathing, you have to look for saturation and respiratory rate of the patient, look for the exposure of chest, and general inspection, look for any tracheal deviation, accessory muscles, absence of spontaneous breathing, percussion and auscultation. So you have to look for any humothorax, pneumothorax in that breathing. Then the next is circulation and hemorrhagic control, where we will evaluate for the peripheral pulses, blood pressure, the heart rate and pulse pressure, and there is any internal or external bleeding. So if there is blood on 4, we have to look for the 4, then the hemothorax, any injury to the abdomen, any peritonitis, any fluid in the pelvis or long bone fracture. So if you think the patient needs a resuscitation, if the BP is low, then establish the 2 large IV bore cannula, infuse warm RL NS 1 liter for adult and 20 ml per kg for pediatrics. Obtain blood samples and reassess the hypotensive patient without an obvious indication for surgery. Then if the fluid resuscitation is not that much good, then it will lead to the lethal triad in trauma. It includes acidosis, coagulopathy and hypothermia. After even you give the adequate amount of fluid, the vitals are not improving. We have to look for the massive blood transfusion protocol, in which 1 pint PRBC, 1 pint FFP and 1 pint platelet have to be infused. Definitive control of bleeding includes surgery, angioembolization, and pelvic stabilization. And the new CRASH 2 trial also helps to tell about the role of tranexamic acid in control of hemorrhage in trauma, in which 1 gram of tranexamic acid IV bolus over 10 minutes have to be given, followed by 1 gram over 8 hours. In disability, we will look for the GCS of the patient, reaction of the pupil and RBS, and in GCS it is categorized severity of traumatic brain injury. 13 to 14 is mild, moderate 9 to 12 and severe. Usually GCS less than 8 is an indication for moving endotracheal intubation. So next one is exposure, where we have to disrobe the patient to look for any external injury, and the main thing in exposure is to prevent the hypothermia by giving the blind light. There are adjuncts to primary survey. After primary survey, the things that we can do which help for the diagnosis and prognosis of the patients are the adjuncts, which includes an ABG, pulse oximeter, carbon dioxide, urine output, catheterization, and ECG. Another one we use is EFAS, in which we can look for any inside bleeding in our abdomen or any trauma to the heart, everything. If you have right upper quadrant, subsequent left upper quadrant suprapubic views. Secondary SNV, it includes history and head-to-toe evaluation, and history includes ample history, allergies, medications that we currently use, past medical history, last meal and events. And it also includes physical and lab investigation. Adjuncts to secondary survey includes spinal X-rays, CT scans, X-rays and ultrasounds. Re-evaluation and definitive care have to be given. To trauma patient must be re-evaluated constantly to ensure the new findings are not overlooked and to discover any deterioration in previously noted findings. Whenever the patient's treatment needs exceed the capability of receiving institution, transfer is considered. This decision requires a detailed assessment of the patient's injury and knowledge of the capabilities of the institution, including equipment, resources, and personnel. Thank you.
Dr. Vishnu, that was a very nice presentation. In your triage, among the colors, what does color brown stand for? When do you use the color brown in a triage? Okay, so color brown is usually used in case of chemical spills. Okay, so that color is used so that the emergency team knows how to protect themselves against contamination.
Okay.
Considering this is a poly injury, poly trauma approach, that is your title.
Yes.
And considering this is a neuro update, I think your people should focus more on, that is my perspective, and more on head injury and spinal injury rather than, of course your title is polytrauma, but here, since we are assembled here for neuro update, more on a neurological, or I think that would be more relevant. That is, keep on more, what do you think?
Thank you.
Thank you, Dr. Vishnu. Moving ahead, we have with us Dr. Vike Tolu Somniel Sore to speak on the topic percutaneous twist drill craniotomy with closed drainage for the treatment of chronic subdural hematoma. With this, I just want to make an announcement, for each speaker, 6 minutes, on 6 minutes there will be a warning bell, and on 8 minutes there will be a final bell, and next 2 minutes will be given for the discussion. Thank you so much.
Good afternoon, everyone, respected teachers, seniors, and my dear friends. Today I'll be talking on the paper percutaneous twistal craniostomy with closed drainage for the treatment of chronic subdural hematoma. Myself, Dr. Samuel, I did DIMB training from Ramon Hospital, Private Limited. Introduction: chronic subdural hematoma is a commonly occurring neurological disease. It is expected to rise in incidence due to the increasing aging population and associated medical conditions requiring anticoagulants and antiplatelet therapy, as well as better imaging modalities. Incidence ranges from 1.72 to 20.6 per 100,000 per person per year. Risk factors are all patients following minor trauma due to associated brain atrophy, alcohol consumption, meal sex, use of anticoagulants and antiplatelets, Alzheimer's disease and other neurological diseases associated with brain atrophy, systemic diseases like which are associated with brain atrophy, such as liver and kidney disease, dialysis patients, and bleeding dialysis, etc. Coming to the pathogenesis of chronic subdural hematoma, the initial injury to the dural border cell leads to CSF and blood entering into the subdural space. It releases inflammatory cytokines with influx of inflammatory cells and fibroblasts, which causes a release of vascular growth factors and ingrowth of incompetent vasculatures. The current concept is a self-perpetuating cycle of recurrent hemorrhage, criminalizes inflammation and angiogenesis. Current treatment modalities includes twistal craniostomy, burr hole, and craniotomy. However, there is no clear consensus on the optimal treatment, and mostly depends on the surgeon's preference. In the age of minimal invasiveness, endoscopic management of CSCH, chronic subdural hematoma has also been studied. A system review meta-analysis done by Elmore et al. Found that percutaneous bedside twistal drainage is a relatively safe and effective first-line management option. These findings may result in potential health cost savings and eliminate perioperative risks related to general anesthesia. Another paper by Liu Weimin et al. They also found that the use of burr hole drill does not seem to make any significant differences in the recurrence rate or other outcome measures. It seems that irrigation may lead to a better outcome. So the aims and objective was to study the surgical and functional outcome following twistal craniostomy. It was done in Ramon Hospital with study duration of 1 year with 43 sample size, including the inclusion criteria and exclusion criteria. So CT grading is done by Nakaguchi grading system. It's classified into 4 types. One is homogeneous, second is laminar, separated type, and trabecular type. The functional scoring system was graded using Glasgow Coma scale, Mark Calder's neurological grading score, and Glasgow outcome scale score. This is the GCS score, as well known. This is the Mark Calder's neurological grading, and the Glasgow outcome scale score. So instruments are usually simple instruments we use: kidney tray, serial gauze, and some forceps, needle holder, sponge holder, a curved stylet, drill bits, handheld drill, and scalpel and knife, and feeding tube of size 8F and 10F. So procedure-wise steps: first we shaving and antiseptic cleaning of the planned area. Local anesthesia is injected at the site of twistal craniostomy. Area is drained on compression of injection area for local spread. A step incision is given by 11 size blade. Craniostomy is performed with the help of handheld tube and entry into the subdural space. So a tender feeding tube is inserted into the subdural space, guided by a curved stylet. The curved stylet helps to adjust the direction of the tube. And removal of the stylet and adjust the depth of tube insertion, and then the drain is fixed with 2-0 seal cover and antiseptic dressing. In our study, maximum patients were in male, and age distribution maximum cases were in the age group of 60 to 69 years. Comorbidities: many patients had multiple comorbidities. Hypertension was the most common, and recent head trauma was present in 25 cases. Coming to clinical features, headache was the most common presenting features, followed by hemiparesis, gait disturbance, autosensory normal. Coming to CT characteristic, the right side was more commonly involved. Frontotemporal parietal location was the most common. Hypodensity was the most common density. Homogeneous type was the most common type, and 27 cases has less than 10 mm midline shift, whereas 16 cases is more than 10 mm of midline shift. So post-operative outcomes, infection was, we didn't see a single fatal infection, but minimum pneumococcus was seen in 8 patients. One cases had a complication of extradural hemorrhage for which a craniotomy was performed. And comparing the pre and post MGS score, there was significant improvement which was statistically significant with a p-value of 0.003. Then at follow-up the patient at 3 weeks and 3 months. The MGS and GOS score further improved. However, they were not statistically significant. Coming to recurrent cases, we had 4 recurrent cases, which was detected at 3 weeks. The demographic and radiological data of the recurrent cases were all patients were above the age of 70 years. The most common type was separated type, and all patients had more than 10 minutes of achieved preoperatively. Coming to discussion, cholecystitis is a currently encountered problem in neurological practice. Many elderly patients with comorbid medical conditions suffer from SDH. They needed simple and short-time techniques to treat. It was first introduced as a diagnostic procedure in 1948. Our study showed maximum number of cases in 69 years. Complications were minimal. There was significant improvement in the MGS score as well as radiologically improvement in midline sheath was present. Recurrence rate was 9.3% at 3 weeks follow-up. And complications and recommendations as twisted craniostomy is a blind technique. It carries the risk of emerging complications such as PDH, acute SDH, and ICH. So based on our experience, a few points to be noted to avoid complications and catheter failure includes: one is estimating the thickness of the bone and adjusting the length of the drill. Twist fast to penetrate the durometer. Drill tip should be sharp. Avoid sudden excessive drainage. Curved tip staggered to avoid parenchymal injury. Confirm the crank oil color hematoma draining and use of a large bore drain. In conclusion, CSDH occurs most commonly in elderly male population. The clinical presentations are variable, with headache being the most common presenting complaint. Multiple modalities of treatment are available, which includes twist drill, burr hole, and extended craniotomy. Twist drill craniotomy can be easily performed under local anesthesia, which mitigates the risk of general anesthesia. It is cost-effective, easily performed at bedside, and a similar recurrence rate compared to other treatment modalities. So there is significant improvement in the neurological scores. The risk of complication can be attenuated by using proper techniques, instruments check, and preoperative planning. In conclusion, twisted craniostomy is an effective, minimally invasive bedside procedure with good neurological outcomes and can be considered a primary treatment modality for chronic subdural hematoma. These are my strengths and limitations of the study. And these are some cases which we have performed for twisted craniostomy for chronic subdural hematoma. Thank you.
Just query saying, in chronic subdural hematoma, suppose due to high protein content and all, there may be some membranous formations. Is it difficult to bring out those blood clots and all? Because inside the feeding tube, it's a very narrow, small tube.
Yes, sir. Sometimes catheter can get blocked because the collection is very thick. So sometimes you might need to go for a repeat craniostomy.
How many cases you had to go for repeat?
Now practice, when we're practicing, at least for recurrent cases, we can do bilateral craniostomy also. We can do multiple sites. But if it's a follow-up recurrent cases, we can perform a second twist drill. Till third cases, we perform at recurrent cases, we can perform for a twist drill craniostomy. After that, we can play for other procedures like we can play for medial meningeal artery embolization or to prevent recurrences.
Okay.
Thank you, sir.
Thank you, Dr. Samuel. Coming to the last session,
I'd like to welcome Dr. Abhigyan Borkotoki, DNB Neurosurgery, to present on enhanced recovery after surgery in spine surgery.
Good afternoon, respected chairperson members, honorable respected faculties, my colleagues, seniors, juniors, and one will present here. So I will be presenting I will be basically giving a presentation in ERAS in spine surgery. So the first concept of ERAS was basically applied to the colorectal surgeries in the year 1997 when these all protocols were being standardized. And the pioneer behind ERAS, implementing ERAS in colorectal surgery was Dr. Henry Callet. And since then, this ERAS grew its branches, and one of the branches came to the spinal surgeries. So the application of ERAS protocol in spine surgery is relatively underrepresented in the existing literature. And although we can find different types of papers or analysis or many articles that are being available, but every article, every paper differs in their own perspective. If one paper says this should be done, other says this should not be done. So there is no any kind of like standardized guidelines that are being applicable for this spine surgeries. So basically, this ERAS in spine surgery is a multidisciplinary approach. It basically starts from the patient and the attendants, then to the operating surgeons, and post-operatively the caregiving sisters or the brothers, and again the responsibility attendant comes when you discharge the patient. So although these ERAS protocols are in their infancy, but they are steadily gaining popularity amongst all these spine surgeons. So existing protocols that I already said that they display they display significant variations in their preoperative, intra as well as the post-op elements, and so kind of like standardizing it to a single protocol becomes very difficult. So the aim and objective was to determine the effectiveness of ERAS protocol in spine surgery, and to see which interventions resulted in better outcome after spinal surgery and compare with the existing literature. This was a study done, our own study in our own hospital. It was kind of like done as a pilot study over a period of 100 days. We include patients who underwent ECDF, MLD, Percutaneous vertebroplasty, kyphoplasty, percutaneous spinal fixation procedures, limited laminectomies, and endoscopic disc surgeries as well. So patients with comorbidities and other persist spinal cord pathologies were being excluded from the study, and ethical clearance was obtained from the institution's ethics committee. So preoperatively, this all thing began 48 hours prior to OT. So once the patient comes to us, we counsel the patient. Then we used to give pregabalin 75 milligram 48 hours preoperatively OT in the OTHS dosing. And then the patient was called for OT on the proposed day of surgery. He was admitted early in the morning, and kind of like after all the written consent and everything work is done, we used to take the patient for surgery. And intraoperatively, we used to give 1.5 gram of ceftriaxone before 1 hour before skin incision. So intraoperatively, the incision was kept as small as possible, and muscle splitting rather than the muscle cutting approach was being used. Percutaneous approaches were used wherever it's possible. Drain and catheters were probably better was avoided. And 1 gram of paracetamol and sometimes 4 milligram dexamethasone was given intraoperatively. And before closing the wound, we used to infiltrate the wound with a mixture of bupivacaine and magnesium sulfate. Post-operatively, we used a paracetamol infusion 12 hourly, and we used to apply ketoprofen patch in the deltoids. And 4 milligram of ondansetron was given only to those patients who experienced post-operative nausea and vomiting. 4 hours post-op, clear water was allowed to the patients. 6 hours post-op, semi-solid foods were being started. And our attending brother or sister, they used to note the pain assessment, they used to do the pain assessment and recording using the visual analog scale. And IF3 resibility was studied 12 to 14 hours post-operatively. And on evening of post-op day 1, the patient was being discharged. Our responsible attendant was explained regarding all the danger signs, symptoms, or to return immediately to us if the pain or any problem the patient faces. So going to the follow-up, telephonic follow-up was done on post-op day 1, day 3 and day 5, and physical follow-up was done 2 weeks after the discharge. So moving forward to the results and observations, we had a total number of patients were 54 during that 100 days interval. So this was the table that is showing the distribution of patients across the different operative procedures that have been considered in our study. 4 patients had post-operative nausea and vomiting. Out of that, 3 were females and 1 was a male patient. And obviously, females are more prone to develop PONV. And if prior history is present, prior operative intervention is present, history is present of PONV, then the patients are kind of like given ondansetron 4 milligram. And this is the table showing the average length of stay for each procedure that we have done. The least was for the percutaneous vertebroplasty or kyphoplasty, which was around 7.6 hours. And the longest was for a percutaneous vertebral fixation, it was around 36.7 hours. So one patient required readmission after discharge. So the cause of readmission was increase in the intensity of pain. And once the patient was admitted, we gave him a proper anesthesia and the patient was discharged the next day. So moving ahead to the discussion part. So the majority of the patient fell within range of 40 to 60 years of age. And female patients accounted for 42.59%, whereas the males accounted for 57.40% in a ratio of 1.34:1. And the average length of stay calculated from our the previous table was found to be around 29 hours. So this is the table showing comparing our study with the variety of the other studies that have been available. So kind of like the parameters that we took into account or the intervention that we performed kind of like varied from study to study, but more or less the length of stay, even the pain evaluation and the intra and post-op use of paracetamol was being used in all other studies that I have compared with. So in the conclusion, utilization of ERAS can be extended to include spine surgeries, provided we kind of like have certain rigorous or strict patient selection criteria. And critical factors in this context encompasses patient motivation and emphasis on effective pain management. So the several notable benefits that we observed during the study was the reduction in the duration of hospital stay, decrease the healthcare expenditures, enhance functional outcome of patients, and better patient satisfaction. So the take-home message, ERAS protocol contribute to a more efficient and patient-centric approach to spine surgeries, culminating in an elevation of the overall quality of care and patient satisfaction. So we did this study and we sent it for a publication, and luckily last month our own article got published in Nepal Journal of Neurosciences. So this was the study, and we are carrying forward our study further with a larger cohort of patients. Thank you.
In the beginning, you mentioned that there are different studies on those particular approach, and there are different views. Every study varies, and if somebody says this and other study says, what according to your study, how different it is, and how can you compare? Very short.
So basically, some studies intraoperatively we have used paracetamol. So some studies they have suggested using contramol infusion throughout the procedure, operative procedure. And post-operatively, we have used paracetamol in a dose of BD. So some have used ibuprofen. So now, kind of like we have seen that we started using ibuprofen now. So we see that we have seen that the pain analgesic effect is much more better managed compared to paracetamol using ibuprofen. That is one of the main difference in pain management.
So your study is more on a positive side, in the scale of positive, better than other studies?
Sir, I cannot comment that my study is much better than it, but it's almost comparable to other studies. Ma'am, we only took patients with only bony pathology. We did not per se take that was the exclusion criteria for study. Okay. Only spinal cord pathologies were excluded. Yes,
you have mentioned between along with Maxal.
Yes,
so what is the use of Maxal in this?
Maxal actually, ma'am, we have seen that it enhances the duration of action of bupivacaine if locally infiltrated, if a mixture is made. So we are routinely now in every procedure, in any spinal surgery procedure, we are infiltrating the wound with this mixture solution.
So you have to see electrolytes beforehand.
Ma'am, yes, electrolytes are safe, but only ma'am, we are using 10 ml of solution. So I don't think it will be making so many electrolyte imbalances.
Thank you very much.
Thank you.
Thank you so much, Dr. Abhigyan. With this, we came to an end of session 1. And I would like to thank Dr. Ashok Kail, Dr. Jayanti Das, Dr. MLA Rahman, and Dr. Maromi Das for chairing the session. Thank you so much, sir. Thank you so much, ma'am. With this, I also would like to invite all the speakers of session 1 to please come forward on the stage as we have a small token of love for you. I also would like to invite Dr. Shamim Ahmed to kindly come and hand over the token of love to them.
रोशन फोटो रोशन फोटो सेंटर से
of the 4 experts and go back to the rewarding sessions.
Please have some round of applause for them.
Just idea with the total cumulative points. Okay, let's proceed for the next session. By the Satish will count. Thank you.
Thank you, Dr. Shamim. Thank you, all the speakers. Moving ahead to the next session, session 2. To chair the session, I would like to invite Dr. Musharraf Hussain and Dr. L.J. Basumaturi to chair the next session. Sir, you can take the chair, yes. Okay. Ms. Angelis, kindly welcome our chairman. To begin with the next session, I would like to invite on stage Dr. Punyabrata Kashyap, MD, DM, Consultant, Neurology, Swagat Hospital, Guwahati, to talk on the topic autoimmune encephalitis, recent updates and management.
Dr. Punyabrata Kashyap.
Before we start, just a reminder, the speaker will get total 15 minutes of time. 12 minutes there will be a warning bell. On 15 minutes there will be a final bell. And next another 5 minutes for discussion. Thank you.
Now I have a very pleasant task of announcing the winners of today's paper presentation. The result goes like this. The first, Dr. Shemuel is the winner of today's paper presentation by scoring highest marks from all the 4 judges, reviewers. Second award goes to presenter number 5, Dr. Abhigyan Borkatugi. Round of applause for both the winners. Third prize goes to second speaker, Dr. Tanuj Agarwal. Fourth goes to Dr. Vishnu, I suppose. Third speaker, Dr. Vishnu. Yes, Dr. Vishnu is the fourth winner. And the final winner is Dr. Alam, Rahil Alam. So congratulations all the winners. Congratulations and more congratulations for your efforts, your labor, and keep going and keep doing good works. I think you can definitely improve much more. And a little comment on the first 3 speakers. As per the our views, it was based mostly on theoretical approach. Okay, so try to make it more practical in future. Personal studies will be more appreciated in different platforms of the conferences, and wish you all the best in the future and also in your career, in your life. Thank you. Thank you so much.
Hello.
फेस तो एकदम ब्लैक आई है ऐसे एक्चुअली पूरा वो जब वाइट हो जाता है ना पूरा फेस उसको उपाय नहीं है क्या
Till the time the next speaker is getting prepared, I request Shamim sir or Satish Bauri sir, are they around? To hand over a gift to the winners. So this gift is from our academic partner. I request all the speakers to come forward. All the 5 papers. Bauri sir, you also have to come here to present the gift. So request sir to hand over the prizes. These are all same. These are just token of appreciation from our end. Thank you. Thank you all. Please have your seats. Thank you.
Cuma kita kaya dah.
A very good afternoon, everyone, respected chairpersons, my seniors and colleagues. Today I'm going to present one very interesting topic, which is autoimmune encephalitis. So before the topic proper, I want to ask one and everyone present here, there is a movie in the Netflix about this topic, autoimmune encephalitis. So how many of you have seen that movie? Please, yes, right answer. So you can watch that movie, very interesting. You can know all the signs and symptoms of autoimmune encephalitis there. So I'm going to start my topic. So this is a group of non-infectious immune-mediated inflammatory disorders that affect the cortical and deep gray matters with or without involvement of the white matter, meninges, or the spinal cord. And together, there we can divide these symptoms into two broad categories. Those antibodies to neuronal cell surface antigens, they affect mainly the cell surfaces and affect the cell physiology. And other group of antibodies which affects the nuclei of the neurons. So these group of cells are called, antibodies are called paraneoplastic antibodies. So we will mainly focus on the neuronal cell surface antigens, which causes this autoimmune encephalitis. They mainly affect individuals of all age groups, but preferentially they affect mostly the children and the younger adults. And incidence is around 5 to 8 per lakhs per annum, and main symptoms are behavior and psychiatric symptoms, seizures, cognitive declines, and most of the patients may have a viral prodrome, nausea, and upper respiratory tract-like symptoms. So, the proposed classification of this autoimmune encephalitis, according to the anatomical classification, we can divide it into limbic encephalitis, cortical or subcortical, striatal, diencephalic, brainstem, cerebellar, encephalomyelitis, meningoencephalitis, or combined or various combination of all these. In the serological classification, we can divide it into antibodies to intracellular antigens, which are classical onconeuronal antibodies, and antibodies to the surface antigens and other antigens with high clinical relevance, and antibodies to the surface antigens with low clinical relevance, and seronegative autoimmune encephalitis. These are the serological classification. And in the etiological classification, we can divide it into idiopathic, where we cannot find any antibodies, both in serum or CSF. Paraneoplastic, post-infectious, mainly after the herpes infections, we may see some cases of NMJ and encephalitis, and iatrogenic. So these are some examples of autoimmune encephalitis antibodies: anti-AMPR antibodies, anti-Casper2, DPPX, GR2, GABA-A. So this affects mainly the cell surface of the neurons, and these groups are mainly associated with the paraneoplastic one, which are cancer associated. So there are some diagnostic criteria of each of the autoimmune encephalitis. So diagnostic criteria for possible autoimmune encephalitis, for that all three of the following should be present. The number one will be the subacute onset of short-term memory impairment, altered mental status, and some psychiatric symptoms. And at least one of the following new focal serious finding: seizures not explained by previously known seizure disorders, CSF pleocytosis, or MRI suggestive of encephalitis. And third will be the reasonable exclusion of the other alternative diseases. Now the criteria for autoantibody negative but probable autoimmune encephalitis, for that all four criteria should be met. First one will be the similar of like the subacute onset of memory impairment, psychiatric symptoms, and altered level of and altered mental status. Then second will be the exclusion of the well-defined syndrome, those we have already known like brainstem encephalitis, ADEM, limbic encephalitis, like that. And the third will be the absence of a well-characterized autoantibodies in the serum or in the CSF. And at least two of the following, that is MRI abnormalities suggestive of autoimmune encephalitis, CSF pleocytosis or oligoclonal band, or elevated CSF IgG index, or both. Or brain biopsy showing inflammatory infiltrates and excluding other disorders. And fourth will be the reasonable exclusion of the alternative causes. Now the diagnostic criteria for anti-NMDA receptor antibodies. Probable anti-NMDA receptor encephalitis diagnosis require all three of the following. Less than 3 months of at least 4 of the 6 following major group of symptoms. Number 1 will be abnormal psychiatric behavior or cognitive dysfunction, speech dysfunction, pressure speech, verbal dysfunction, verbal reduction or mutism, seizure, movement disorder, or dyskinesias, rigidity or abnormal postures, decreased level of consciousness, autonomic dysfunction, or central hypoventilation. Number 2 will be at least one of the following laboratory study results: abnormal EEG, focal or diffuse slowing, or CSF with pleocytosis or oligoclonal bands, and reasonable exclusion of the other disorders. These are the criteria for possible probable anti-NMDA receptor encephalitis. Diagnosis can also be made in the presence of systemic teratoma with the all three categories I have already discussed. And the definitive diagnosis of anti-NMDA receptor encephalitis can be made in the presence of one or more of the 6 symptoms in the presence of anti-IgG, anti-GLU1 antibodies. Now, the diagnostic criteria for definitive autoimmune limbic encephalitis. Diagnosis can be made with all 4 of the following criteria. Number 1 will be subacute onset, that is less than 3 months of working memory deficit, seizure, or psychiatric symptoms. Number 2 will be bilateral brain abnormalities on T2 weighted or flare sequence restricted to the medial temporal lobe. And at least one of the following: EEG with epileptic or slow wave activity involving the temporal lobe or CSF pleocytosis. And number 3 will be at least one of the following: EEG with epileptic or slow wave activity involving the temporal lobes or CSF pleocytosis, and reasonable exclusion of the other alternative causes. So step-by-step diagnostic approach will be: first we need to do one MRI. After strong clinical suspicion, then we can take the help of EEG. If these two are non-conclusive, we can go for a brain PET scan. Then in the second step, we can confirm inflammatory etiology to rule out competing other possibilities. We can do the lumbar puncture for detection of antibody in the CSF and then in the serum for autoantibodies. If these are also inconclusive, we can go for brain biopsy. Then in the third step, we can look for the cancer in the body for paraneoplastic antibodies. So in the MRI finding, according to the 2016 autoimmune encephalitis clinical criteria by Gross et al., the presence of bilateral limbic encephalitis is the only MRI finding sufficient to diagnose definite autoimmune encephalitis in the correct clinical setting. It doesn't need the autoantibody. And the diffuse or patchy contrast enhancement is suggestive, while intense contrast enhancement are unlikely. So these MRI. So this is the MRI image showing this involvement of the limbic, this hippocampal area in anti-LGI1 encephalitis. That is leucine rich glutamine activated 1 encephalitis. And some other pictures which shows the hippocampal involvement in the limbic encephalitis. This shows cortical and subcortical involvement. Here you can see the caudal involvement and the striatal involvement. here the diencephalic involvement, brainstem involvement, and in meningeal enhancement we can see. So it can affect the different parts of the body according to the involvement. And the EEG, how EEG helps? EEG mainly helps to diagnose any new onset refractory status epilepticus or detect any abnormalities which MRI can miss, or it can monitor the treatment. Suggestive findings in atopic encephalitis are focal swelling, lateralized periodic discharges, and extreme delta brush. And it can also differentiate from CZD. However, normal EEG doesn't exclude atopic encephalitis. So this EEG can show this delta brush. Here, superimposed beta wave you can see over the delta. So this is specific for anti-NMDR antibody and encephalitis, which will be found in 10 to 30% of the cases. Now we can take the help of FDG PET, can confirm focal or multifocal brain abnormalities. Some findings are bilateral temporal hypermetabolism is seen in limbic encephalitis, and bilateral occipito-parietal hypometabolism is seen in NMDR encephalitis. And other specific diagnostic methods are cell-based therapy and tissue-based therapy. This picture shows this is the brain hippocampus of the rat brain. This is treated with the serum of patient with NMDA positive encephalitis, and this is treated with a normal person's serum. So this shows the reactivity. And here these dotted things are the cell surface antibodies. Now the important points. Previously it was said that CSF is not mandatory, but now they have recommended that CSF is also mandatory for initial evaluation, because around 30% of the cases which are serum negative may be CSF positive. And some antibodies have propensity to be more specific in the CSF. So these are some differential diagnosis. I will not go into details, it will take more time. So I'll go to the therapies. So we have first line therapy and the second line therapy. In the first line therapy, we have three main agents: the methylprednisolone, intravenous immunoglobulin, and plasma exchange. In the second line therapy, if the first line therapy fails, we can go for second line therapy. After 2 to 4 weeks of first line therapy, if the patient doesn't improve, we go for second line therapy, that is rituximab and cyclophosphamide, according to the antibody categories. I'll discuss it. And if the patient doesn't improve, then we can label it as a refractory atopic encephalitis case. Then we can go for alternative therapy, which is the newer therapies like tocilizumab and low dose interleukin. So these are the newer therapies. Daratumumab, tocilizumab, this all acts in the periphery, while this intrathecal methotrexate and natalizumab, they act mainly in the CNS directly. So these are the newer therapies. So how to approach, how to treat the patient. So if the patient is highly suspected of confirmed autoimmune encephalitis, if the tumor is present, we will treat in the line of onconeuronal antibody, that is paraneoplastic syndrome. And if the tumor is absent, there is a possible idiopathic autoimmune encephalitis. If the symptoms are mild, to moderate, we can go for any three of the therapies, which is methylprednisolone and IVIG or plasma exchange. If patient doesn't initially respond to intravenous methylprednisolone, then we can go for IVIG or PLEX. If the initial symptom is very severe, we can directly go for combination of intravenous methylprednisolone plus any one of the IVIG or PLEX. If all these three treatment fails, then we can go for rituximab, which is second line of treatment. If no improvement, we can go for cyclophosphamide. And we can go for cyclophosphamide directly if we find these paraneoplastic antibodies. Again, if we do not find any improvement, then we can go for the newer therapies. So these are the treatment algorithms. Some best practice recommendations are there. Like First of all, we need to do CSF plus serum with the search for antibodies in both CSF and the serum. Then we can take help of FDG PET. Then if we don't find any antibodies which are specific for the symptoms, then we can go for cancer screening. And if there is no clinical or radiological improvement, 2 to 4 weeks after the completion or combined acute therapy, consider starting second line therapy. I have already discussed. So I want to show the faciobatial. Not displayed here. So I wanted to show the facial-brachial dystonic seizure, which is specific for NTLGI. This is the facial-brachial dystonic seizure this patient is having. So this kind of seizure can be seen in anti-LGI or anti-Casper antibody positive cases. So this was the movie I was talking about. So brain on fire, it's not supposed to happen, but be prepared when it does. My references. Thank you so much.
Thank you, Punawat. Excellent talk. So, is there any question from the house?
Okay, so one more aspect of the autoimmune encephalitis is how do we maintain, how to go for a maintenance therapy of this patient?
For autoimmune encephalitis, after the subsidence of the acute symptoms, we can go for maintenance therapy. We have to do slow tapering of the steroid. Along with that, we can start steroid sparing agent like azathioprine, 1 to 2 mg per kg, and mycophenolate mofetil. But in case of paraneoplastic syndromes, we prefer to taper it in a short course of steroid.
So rituximab is also many times we use for maintenance therapy.
Yes.
So I want to ask, not you, but Lokada and Master sir also. So, like, what will be the this maintenance regime for rituximab? Should you go for 1 dose? Should you go for 2 doses? And will the CD20 or CD19 what we see? So, can we depend on CD19 also in this fact, like CD19 is?
Yeah, it's a very interesting topic for all the neurologists, including movement disorder psychiatrists and those who practice peripheral nerves, because it encompasses all this, apart from traditional neurological symptoms like psychiatric symptom, movement disorder, etc. So now here you will miss 2 points here. You will miss 3 diagnoses if you take a cutoff of 3 months interval. That is the guideline. The diagnostic guideline is subacute onset of autoimmune encephalitis. That is should be done, should happen within 3 months cutoff. So what are the 3 things you will miss here? Because there are 3 entities which present as subacute or chronic. Okay. Number 1 is LGR1. Number 2 is Casper2. Number 3 is IGLON5. So they can present up from 1 year to 5 years. They can sometimes even mimic degenerative disease like. For example, IGLON5, if you do a proper testing, you will see 3 repeat and 4 repeat tau. So that is indicative of degenerative disease, okay, tauopathy. So that is very interesting. So that is why you should not be limited yourself to 3 months, 3 months period of diagnostic cutoff. You should extend it if you have a strong suspicion. Okay, and number 2, the question asked by Hemango. The prognosis of different kind of autoimmune encephalitis is different. For example, Agilon, they have a high rate of recurrence, more than 50% they recur. Casper and LGI, they don't respond well. So, when you monitor the patient clinically and as well as CD19, so I think that will give you the result. So you can maintain the patient with rituximab based on the clinical and the CD19 report.
Similar to like we do in the NMO antibodies in positive cases. Like can we extend the duration according to response from 6 months to 9 months, 9 months to 12 months?
Is there any definite guidelines for that? Guidelines are missing.
Guidelines.
There's no definite guideline. It is very individualized. And sometimes, like other than this very clear-cut entities, even HSV encephalitis after they recover can end up with autoimmune encephalitis. So after the recovery also they can have the autoimmune encephalitis. So the spectrum is ever increasing. This spectrum is ever increasing. And sometimes we think, is it really like ever increasing, or sometimes we are over-diagnosing it. Okay, so it depends.
Because even with SLE patient, even with SLE patient you get LMD.
And the spectrum is really increasing so much that the table of autoimmune encephalitis is ever increasing. Every new textbook, new edition comes, you'll see a huge next 2-3 pages of autoimmune encephalitis. Another one comes, again 2-3 pages. So are we really getting the gist of the thing, or is it just a bystander type of phenomenon in some cases?
And there is also controversy regarding how long you will continue this therapy, this maintenance. You will continue for 5 years, 3 years, or lifelong. So this is also again a very big question. So many patients like which we are following. So it is very difficult to answer them, sir, how long will continue this therapy. So that's it.
Yeah, but it's an excellent talk, and I think we will close for other person now.
Thank you, Purna. Your presentation is very nice. Actually, after passing DM examination, I have seen today only.
This is my first talk This is my first talk after passing.
After passing DM examination. Anyways, best wishes.
Thank you.
Have you encountered IG non-antibody positive autoimmune encephalitis?
During my residency, I have found one case, but unfortunately they didn't undergo the antibody test.
Yes, one antibody tested done outside. It was positive, and then we have referred the patient to nephrology for plasmapheresis.
I think after
patient,
I left.
Yes, after that only you passed on.
That's great news.
Yes, patient complained of only sleep problem, chronic sleep problem. They have went to CMC Belor, and there they have done some investigations. And after that, patient came with positive.
Okay, that's great to know. Thank you.
You too.
Thank you so much, sir. I'd request Ms. Angelis to kindly give a token of love for Dr. Punya Kashyap. Moving ahead to the next session, I would like to invite Dr. Deba Borgohain and Dr. Manoranjan Gairi to chair the next session. I would like to invite Dr. Deba Borgohain and Dr. Manoranjan Gairi to chair the next session. We would like to welcome the chairperson with a token of love and appreciation.
स्टेज में इसी का वो दीजिए साइड से इस साइड से इस तरफ से ले
So Dr. Dr. Nabarnil Porar, we'd like to invite you to be the chairperson.
Requesting W. Guru sir to kindly guide us for this next session, along with Dr. Deba Borgohain.
लगने से नहीं होगा। ठीक है।
So let us welcome the next speaker, Dr. Deep Datta, consultant neurosurgery, Apollo Hospital, Guwahati, to share his experience with meningioma.
Good afternoon, respected teachers, my seniors and my dear colleagues present over here. Today I welcome you all to Neuro Update 2025. Let us discuss on meningioma. My topic is meningioma, a curable brain tumor, our experience at Apollo Hospital, Guwahati. So, meningiomas are common, typically benign intracranial tumors arising from meningothelial cells. It accounts for 30% of all primary brain tumors. They are usually benign and slow growing, with a high rate of surgical cure when accessible. So, although they can occur at any age, they are most frequently diagnosed in the middle age and older adults, with higher prevalence in females. Let us go through the history. In 1922, Harvey Cushing coined the term meningioma to describe a benign global tumor arising from the leptomeninges. Eisenhower believed meningioma arises from arachnoid capsules that are particularly abundant in the arachnoid granulations. Virchow was the first to describe classic pathological features of meningioma with the term Shamamo bodies, which are sand-like granules that are found in the tumor. And we all know in 1957, Donald Simpson's paper was published, which described the correlation between surgical resection of meningiomas and the rate of symptomatic recurrence. So, classification of meningioma, you see that the grading is done according to the presence and number of mitotic features, overall cellularity, nuclear and cytoplasmic ratios, nuclear prominences, then the presence of necrosis. Though the majority of meningiomas are benign, which are grade 1 tumors, 22 to 24% of the tumors are atypical of grade 2, and which are mostly aggressive, and they usually recur. And out of them, 1 to 3% are found to be anaplastic, which are grade 3, according to the new WHO classification system. The location of the meningiomas, you see the parasagittal meningiomas accounts mostly in 20.8%, then convexity meningiomas, and if you see the skull-based meningiomas like tubercular cellular meningiomas, spinal ring meningiomas, olfactory group meningiomas, falcine meningiomas and CP-angle meningiomas are 8 to 6%. Then coming intraventricular meningiomas, territorial meningiomas, supracellular meningiomas, middle fossa meningiomas, foramen magnum meningiomas are also seen. Then other meningiomas may occur in orbital regions and spinal meningiomas and multiple other sites, with pineal, intrasylvian and extracalvarial. The clinical features of meningiomas, they vary according to the site and the size of the tumor, and even if there is any intraventricular, intratumoral leak, then we may see the symptoms like of raised ICT because of mass effect. Then we can also localize the tumor using because of the different location of the tumor according to the signs and symptoms will vary. So symptoms grading is like grade 1 is macroscopically complete resection of the tumor with the attached dural tail, with dura, and also the abnormal bone. If it is invaded the bone also, then if it has invaded the bone, then we have to remove the bone, and sometimes the involving venous sinuses also excised in relevant cases. That is grade 1. If it is like grade 2, macroscopically complete resection of the tumor with coagulation of the dural attachment. Grade 3 is resection of tumor without coagulation or excision of dural attachment, and grade 4 is partial debulking, and 5 is just a biopsy if it is very eloquent reason. And grade 1, 2, 3, 4, and 5 were like recurrence rate is like 9%, 16%, 29, 39, and 99%. With the patient's survival for 6 months or longer after surgery. More recent studies, however, suggest that recurrence-free survival is not significantly different between patients undergoing Simpson's grades like 1, 2, 3, or 4. Despite this, the Simpson's grading of surgical resections should be the part of the routine reporting of surgical results, as it resects more subtle involvement of the dura, arachnoid, arteries, veins, and nerves that only the surgeons can observe at open operation and is not always obvious on routine post-operative management resource imaging. So in our studies, we have done just a study on 17 cases of meningiomas in the last year, in 1 year, and a review of literature supports the notion that complete surgical resection is often curative with adjuvant radiation reserved for atypical or malignant cases only. Our patient reinforces the favorable prognosis of meningioma when appropriately managed. In our studies, we have seen that the mean age was around 52 years with a female-to-male ratio of 2:1. The majority patients presented with headache and features of raised ICT and also seizures. And some patients also had focal neurological deficits. Surgical resection was performed in all cases, with 14 achieving Simpson's grade 1 or 2 resection. 3 patients with atypical meningiomas received adjuvant radiotherapy. Follow-up showed no recurrence in 15 cases, although they are in the follow-up, still under follow-up, with 2 requiring additional treatment like focused radiotherapy. We are sent to Apollo Delhi for JAPEX, where we give a focused radiation. Let us discuss on some of our cases that we have done in the last year. So this is a case of 39 years old female presented with headache and weakness over left side of the body. On evaluation, she was having right frontal convexity meningioma. Then after total resection, this was the biopsy came to be fibroblastic meningioma, CNS grade 1. So she didn't require any radiation. And then this is a second case with elderly female presented with headache on and off with dizziness. On evaluation, there was a right septal meningioma through right retromestrual suboccipital craniotomy by microscopical excision of the tumor achieved. Post-op, she tolerated well and her symptoms subsided. You see some videos, small video though. I can see this retromestrual suboccipital craniotomy, and you can see the nerve complexes. In this one, 7 and 8 nerve complexes, and you can see the tumor. And we have resected the tumor, although we have also referred for radiation for the residual tumor. This is a case presented to us with 2 episodes of GPCS, and the patient had headache. On evaluation, the CT revealed left parasagittal meningioma. And then, in the small video, after the dura, we have a parasagittal patient is in supine position, and we have resected. She developed severe headache, most probably because she had a intratumoral bleed. Case 4 is a 25 years old female. She came to the OPD with left-sided hemiplegia, weakness on the left side of the body. And on MRIs, her showed a falcine meningioma. We could remove the tumor, and the surgical consideration we considered a high parietal craniotomy. Then meticulous dissection with total tumor removal achieved. This is the MRI report showing a right falcine meningioma. Then we done a high parietal craniotomy. And a flap was removed, then dura is open, and then you can see the pulse here. Keep it. This is a case 3 years old female patient presented to us with a tumor in the skull base. We have done a cortical transcortically we have removed this tumor. A 31 years old female patient presented with weakness of the left upper and lower limb. She is a healthcare profession. She is a nurse by profession. She came from Nagaland, and when she came to our OPD, she was limping, and on MRI we see that there is a convexity meningioma. After proper evaluation, we did the resection of the tumor. It was a total resection. And in the Simpson's grade 1, we have to remove the dura also as the tumor invaded the dura and some of the bone. The bone we have kept it, we have coagulated the area where the tumor is invaded. Then on histopathology came out to be transitional meningioma. 1 month after the patient came to the OPD, there was no any deficit. She was walking, and she was very happy because of this. Although she asked about the recurrence, because the bone was also involved. But histology shows grade 1, so we did not refer the patient to radiotherapy. It's a posterior hyperparietal meningioma. Patient presented with visual disturbances and headache. The patient is a 38 years old female, and her biopsy showed meningothelial meningioma. Chain is grade 2. Patient is in a patient is a prone position, and in the occipital flap made and the craniotomy done, and with meticulous dissection, whole tumor is could be resected. Most of the tumors would be. From my view, I think the tumors should be coagulated, and brain retraction should be as much less as possible, and we should respect the brain, and the tumor should be the target always, and the vessels should be coagulated, and if required, CT angio should be done preoperatively. So this is a case of foramen magnum meningioma in a 56 years old female presented with neck pain and paresthesia with associated spastic quadriceps of all 4 limbs, right, more than left. On MRI, there is a anterior meningioma, mostly on the right. Then approach, we took a posterolateral approach. And initially we did a occipitocervical fixation done over the left side, only left side, not on the right side. The right side we have done a C1 posterior arch partial resection to reach the tumor intradurally. Then we can we approached. We have after dissecting the dura, opening the dura, we just approach the tumor, and then microscopically we remove. It's a firm tumor. operation was well tolerated, and patient post-operatively she has improved, and there was no deficit, and she improved a lot with physiotherapy. Little bit risky this area because of vertebral artery. We have to be more meticulous, and traction should be less. The whole tumor has come out. You can see that the bleeding was not there over there. And we have closed the dura. There is a recent case we have done. A patient came with proptosis of the eye. We have done a FTOZ craniotomy. Not in FTOZ, but it's a minimal mini FTOZ, where we have done only the orbital part mostly. Then this orbital tumor, this also came out to be meningioma, WHO who grade 1. Then as you can see, the immediately post-op, the patient had proptosis was reduced. Eyeball was preserved, as we had our ophthalmologist who helped us in this operation. So, review of literature, epidemiology and risk factors, ionizing radiation and genetic predispositions such as NF2 mutations are recognized risk factors. Symptoms depend on tumor location. And as I told earlier, MRI is the contrast, is the gold standard for imaging. And in case of skull-based melanomas, we should always go for angio. Preoperatively, we may, for highly vascular tumors, we sometimes use preoperative embolization, and we have done few cases with like olfactory groove meningioma, although I have not shown in the video. We have done pre-op embolization. Then we have done the tumor. And then also that helps in a little bit of bloodless surgery, less of the blood during dissection. And although I have seen that sometimes it also post-op healing is a bit sometimes it gives less of healing if you do pre-op embolization. Although I have to look up the studies. Benign meningiomas have excellent outcome post-surgery with a 10-year survival rate exceeding 80%. So meningiomas are largely curable with appropriate management. Surgery remains the cornerstone of treatment with radiotherapy reserved for high-grade tumors. Our case series aligns with existing literature, reaffirming the excellent prognosis to benign meningiomas. Early detection and complete resections are crucial for optimal outcomes. High rate of tumor control with loss of resection. Importance of surgical expertise in skull-based meningiomas. And recently, we also have to be expertise in endoscopy, skull-based, and then pituitary surgeries also we have to be expertise. Role of adjuvant radiotherapy in Hook grade 2 and 3 tumors. Tumor location and critical structures involvement is a challenge. Management of recurrent or aggressive cases is a challenge. So advancements in molecular profiling, peripheral profiling helps to give a good idea of prognostication, and development of targeted therapies like JAPEX using targeted radiotherapies, which whether any meningiomas are in local areas or in a recurrent meningiomas, we may take help of targeted radiotherapy. Thank you for listening.
Yes, Dr. Deep, it was a good presentation. You have an impressive scene. But I have reservation with your caption. You said that meningioma incurable brain tumor. Do you mean to say all meningiomas are curable? Your presentation doesn't say so. Yeah. Even if you are not able to do a grade 1 or grade 2 in every case. So obviously it may not be curable. Or it may be in such places where you cannot operate without damaging a vital structure. For example, if the sphenoid has degraded one of the major vessels of the brain, you would obviously not be able to excise it completely, and obviously it is not curable. And the WHO grade 3-4 meningiomas will obviously not be curable. So I have reservation with the curability part of it. Yes.
You can say that
meningiomas are benign, so the chances of cure are better. But to make a very general statement that all meningiomas are curable and all gliomas are, it's like saying all gliomas are not curable. It's not, both the statements are wrong. So I think that is one thing. Another point which I would like to make is that you said posterior lateral, but the description of the surgery was actually far lateral, because you would not get anteriorly placed foramen magnum meningioma by just posterior lateral. You have to go pretty lateral, far lateral to get into that place. So although you described, but you made a mistake in the nomenclature. So these two things I point out. Over to comments from Dr. Devo and others.
Overall, very nice presentation.
He wants to ask a question.
Well, we have almost meningioma. You have well shown about the literature, your surgery. In the meantime, you have shown none of the patient. You have shown the MRI film or CT scan. What I feel, pre of all meningioma, at least you should have good angio as well as venography, because venous drainage is very important. While you are dissecting even a convexity meningiomas, you have to respect the blood vessels, and mostly the vein. Many times what happens, you coagulate unintentionally and end up with venous infarct. So that is one point I just want to add to you.
Yeah, I'm Dr. Bernard Shillong. So you said that you have to dissect with less traction on the brain. So I've seen that nowadays we hardly use retractors. So some of the cases I saw you using retractor, and you're trying to take out en masse. I've seen several of that. You've shown that you've taken out en masse, especially the foramen magnum one. You've taken out en masse. So with taking out en masse, I'm sure you must have done a lot of traction for it. You understand that?
I have this video is a part of the operation actually.
Okay.
Initially, as you are right, I also agree that we should always go to piecemeal.
I've not seen you use Kuza.
This is just a video where only that part which was animals taken was taken. The rest of the rest of the tumor, I have dissected piecemeal initially. Then that small part, although in the microscope it's a bigger one, that was taken analysis.
And nowadays I don't think there's anything called...
Because the tumor was very firm. We could not do piecemeal at that time. And there was space although that could come out.
Another thing is there's no more radical resection of meningiomas. Even if it is going into the sinuses and all, we don't take it out because we have radiation. Very pinpoint radiation nowadays to deal with that. So again, what Dr. Navneet said, it is a
convexity meningiomas.
Majority
convexity meningiomas are those tumors which we are in the convexity. So those tumors, as you also know, that convexity meningiomas we can do en masse. But that I have already mentioned. If it is suppose a skull-based meningiomas, then we have to always go for piecemeal.
Okay. No, what I was saying is like what Dr. Navneet said, that this is maybe a majority curable disease, but not absolute curable disease. No?
Yeah, that is. Although I accept this, the topic was actually I have selected. Although I have not selected that topic, the topic actually was it's a part of the discussion to show that we want to focus that some tumors, unlike gliomas, they are mostly curable. Because if, as a general public, not for the doctors, although for general public they think that tumors means it is not curable always. So that's a little bit of focus. And when we go to deeper studies, then already I have mentioned that the atypical tumors, then malignant meningiomas, and these are granules are there. So this is how to just describe the topic and to say some for and against the topic that I have used the topic.
What is your experience with intraventricular meningiomas? Have you had any of them?
Intraventricular meningiomas, it's mostly from arachnoids. Sometimes.
No. Did you have any cases that you did any intraventricular meningiomas?
Intraventricular meningiomas, few cases, sir.
One more comment. One more comment. You said this is mostly for the young neurosurgeons. You said that the brain has to be protected. Now, how do you do it?
Brain protection, limited handling of the brain. Even I don't handle the brain. I only touch the tumor. I used to coagulate because we have to coagulate the tumor. That what I have to. My teacher has asked me that we have to coagulate the tumor, and then brain has to be less related. Always we have to be always
You get the question. You go on my point. No, that is not the. See, almost all meningiomas when you open, first you see, because meningiomas are like not separate from the brain. You see, okay, it's an extraction, but there will be a covering of one
layer of
and you have to take the brain away at least at the periphery. So how do you do it best? Basically, stay subarachnoid. Because arachnoid membrane has to be honored. It has to be intact. Once you keep the arachnoid membrane intact, the chances of brain damage is very, very minimal because you're not touching the brain. So dissect the arachnoid from the tumor first. So that way, once you put cotton patty, after dissecting it out, then it's safe. See, I'll tell you, Vardan said you have to take out piecemeal. Yes, very true. But I do a technique. I just put in a silk thread through the, if it's not very vascular, I put a silk thread into the tumor. I use that as a traction and just dissect the tumor out. And the tumor sometimes pops out in toto. So you can do it provided you have not violated the subarachnoid membrane. That if the brain is covered with that subarachnoid membrane, surely there won't be any damage.
Have you heard of any hydraulic dissections?
Hydraulic personally, I don't prefer so much because it also gives injury to the brain sometimes, as I feel. But it's a good technique. But the force would be less.
I think we have to wind up now.
Thank you.
You already overshot and we are also overshooting. So thank you very much.
Thank you, sir.
Thank you so much, sir. Sir, we would like to invite you on stage for a small token of love, sir. Dr. Deep, do you want you on the stage, sir? I would like to request Ms. Vinita to kindly hand over the token of appreciation to Dr. Deep Datta. And I also extend my thanks to all the chairpersons who has chaired the session. Moving ahead, I would like to invite Dr. Rupjyoti Das, neurologist, GNRC, Dr. J. Kurmi, psychiatrist, Silchar Medical College, and Dr. Himanga Dhi, neurologist, AIMS Guwahati, to chair the next session.
Good afternoon, everyone. I would like to invite Dr. Utpal Bora, MD, Associate Professor and Head in Neuropsychiatry, to deliver his talk, Evidence-Based Management of Neuropsychiatric Symptoms of Parkinson's Disease.
we just want to extend our token of appreciation for the chairperson.
Good evening all, and thank you Dr. Shami Ahmed and team Apollo Hospitals for giving me this opportunity talking in front of this others gathering. Can I proceed, Chairperson, please? Yeah. So my topic is evidence-based management of neuropsychiatric symptoms of Parkinson's disease. We all come across Parkinson's disease in our day-to-day clinical practice. WHO data says that the prevalence of Parkinson's disease has doubled in last 25 years. Probably around 8.5 million people are living with Parkinson's disease globally, and it is responsible for more disability and death than any other neurological disorder probably, and it contributing to 5.8 million disability-adjusted life years yearly. Although data on Indian data are sparse, but the available data and meta-analysis of those studies says that probably around 15 to 43 cases per lakh people we have suffering from Parkinson's disease, and it may be the highest number of people of Parkinson's disease in the world. One important finding is that among the Indian patients, their age of onset is quite younger, it around 51 years, which is younger than the global average. We all know the triad of symptoms in Parkinson's disease, but other than those typical neurological symptoms, all psychological symptoms and a myriad of other physical symptoms are core to the presentation of Parkinson's disease, at various stages of the illness. And the motor symptoms, in fact, are only the tips of iceberg probably. The non-motor symptoms that people usually don't see and don't complain, and maybe the most difficult to treat or address at times. So that comes what are the neuropsychiatric symptoms? When you talk about neuropsychiatry, it may be a prototypic illness that describe the term neuropsychiatric itself. It can be called the prototypic neuropsychiatric disorder or quintessential neuropsychiatric disorder. It is frequently undeclared by the patients, and this can often precede the motor symptoms even by years to even to decades. Profound negative impact on patients' social functioning and ability to walk. So the presence of neuropsychiatric symptoms increases that social dysfunctioning level. And you see the activities of daily living in people suffering from Parkinson's disease as the disease progresses. So the deterioration due to progression of the Parkinson's disease over time. And as over time, the number of medications probably also increases, and that have its own side effect profile, and that causes further deterioration probably in activities of daily living in day-to-day life. Now, while dealing with these symptoms over times with medications, there are certain symptoms like impulse control disorders, dopamine agonist withdrawal symptoms, or dopamine dysregulatory symptoms are there that we need to address. Now, although these symptoms have been there for years, in fact, from the very beginning, these depressive or other psychological symptoms were recognized. But the studies on neuropsychiatric symptoms probably has been seen in a great increase in last 20 to 25 years. Now, as you see in the previous slide, probably the highest number of studies are for depression than to cognition and psychosis related to Parkinson's disease. In his original paper with that shaking palsy, James Parkinson himself mentioned that a more melancholy object I never beheld. Means it was quite prominent, depressive symptoms were there at times too. Now, the prevalence of clinically significant symptoms being around 35%, although other depressive symptoms may be more in percentage, but clinically significant around 35%, and depressive symptoms being more prominent in the motorically off state. It is associated, whenever it is there, it is associated with reduced quality of life, worse level of visibility, cognitive impairment, and increased mortality and morbidity. What are the predictors? The predictors for depression in Parkinson's disease are female sex, increased physical dependence, high liver overdose, more severe motor impairment, pain symptoms, daytime sleepiness, and probably Parkinson's disease patient with that Parkin mutations. How to address it? The pharmacological and non-pharmacological management. As depressive symptoms are little more common, we will discuss in little details about this. Around 25% of patients with Parkinson's disease may be on antidepressants at any time during the course of the disease. Commonly prescribed are SSRIs, SNRIs, and TCAs. But you know that SSRIs are more frequently used and prescribed compared to TCAs because of their side effect profiles. Now, people have done lots of studies with almost all kinds of antidepressants, but the meta-analysis of all these studies shows certain inconsistent results to give what is should be prescribed. So, the treatment of depression PD, which is better, TCA, SSRI, or SNRI? So, the study says that probably they are equally effective over time. TCA shows responses in shorter time compared to SSRIs or SNRIs, but more side effect profile of TCAs compared to SSRIs. So in the conclusion, although definite recommendations cannot be proposed, the first choice agents for PD depression are citalopram, in that case for now it is escitalopram, venlafaxine, and paroxetine, followed by tricyclic antidepressants. Given that there are no relative contraindications for these drugs, in some cases, definitely we cannot give venlafaxine because people who are hypertensive, cardiac problems, will go for that. For the other drugs used in depression, dopamine agonists. Now, it itself being used as a main drug of Parkinson's. So, some beneficial effects on PD depressions are seen. Recently diagnosed patients at the early stages of Parkinson's disease, it shows good responses. Probably patients without psychotic features and who are without increased risks of impulse control disorders, because it is found that dopamine agonists are the more precursor of these impulse control disorders. But in those cases, it helps, and depressive symptoms are closely related to the off phases of motor fluctuations. Monoamine oxidase inhibitors, although not available here in our country, but they show greatest efficacy of PD depression. They are generally well tolerated and effective, especially for patients at early PD stages. Coming to non-pharmacological management of depression. We all know psychotherapies are there, but what kind of psychotherapy? CBT. Cognitive behavior therapy and certain psychodynamic psychotherapy has been found to be effective. Amongst others, but nowadays probably are more frequently used are neuromodulation techniques, RTMS, and transcranial direct cortical stimulations. So other therapies are also there. We will not go into details of that, but please talk about CBT little. These are more commonly prescribed wherever it is available, and all those randomized clinical trials and meta-analysis shows they have demonstrated CBT as an effective non-pharmacological strategy for Parkinson's disease depression. Probably have greater effect compared to antidepressant medications, and intervention period of more than 8 weeks were found to be superior compared to lesser weeks. And definitely, people who are addressed directly means non-group therapy are advantageous compared to group therapy, and it is found that the effects are more sustained over time when it is at least given for 8 weeks or more than that. ECT itself definitely is a significant improves the severe depressive symptoms, but for the issues of comorbid conditions, cardiac issues, and one most important thing, that consent obtainment, the limitations of this effective therapy is seen. Temporarily, we find confusion, disorientation, delirium, although there are no long-term side effects of that. Other non-invasive brain stimulations, meta-analysis have revealed that RTMS in the prefrontal cortex can indeed alleviate depressive symptoms in PD. Effectiveness of RTMS with that of antidepressants did not show significant differences. Means almost probably equally effective, but the studies are although limited. RTMS in combination with antidepressants are more effective for PD depression. RTMS was well tolerated without any side effect profiles. But in summary, that no optimal treatment for PD depression can be currently recommended, that this is optimum. But it should be individualized depending on the patient's comorbidities, general health status, medications he is getting, severity of depression, stage of the illness, and definitely socio-economic condition. As general recommendation, pharmacological therapy is usually first suggested. Wherever available for minor symptoms, non-pharmacological interventions should be first choice. Anxiety. Now, anxiety symptoms frequently coexist with depression, you all know that. But important to determine if symptoms are consistently present or are occurring as a part of NMS. These are best managed by PD medications, means Parkinsonian disease medications. Low dose of alprazolam or lorazepam may be used for generalized anxiety symptoms, but there are proper RCTs are lacking. There is only one RCT for treatment of anxiety in PD that shows efficacy of buspirone only for that. The first line psychopharmacology for anxiety in PD is typically an SSRI, although RCTs are not there. The experience that we have with SSRIs over the 3-4 decades. So that gives us the confidence, and also in clinical practice we see that SSRIs are the first line of treatment. But we should carefully monitor because there may be worsening of cognitive symptoms, gait disturbances, or in fact sleep problems. CBT again, the main cognitive behavior therapy again is significantly superior to clinical monitoring of or reducing situational anxiety that these people usually have. The avoidance behavior that the Parkinson's disease people usually develop over time, and the social anxiety that they have. Modified mindfulness-based cognitive therapy for treatment of anxiety is a growing area of research. Psychosis. Long-term cumulative prevalence is found to be around 60%. Psychosis occurs with increasing frequency as the disease progresses. Psychosis develops particularly in those with cognitive impairment, and Parkinson's disease psychosis is uncommon in patients where these are not treated. Means probably treatment has a significant role in developing these symptoms. Management, how we treat it? First line management of this psychosis in Parkinson's disease will review the medication, reduce the dopaminergic medication dosages if it is possible. We need to exclude delirium where you find more visual hallucination and non-systematized delusions that are characteristics. Must include current infections. Pneumonias are not uncommon. Sometimes we are seeing the following up the patients. Patient comes with aggravation of symptoms. We increase the dose, or add an antipsychotic. We see later on that the situation deteriorates. Rather, I've come across in clinical practice that many people sometimes need those treatment for pneumonia, which is usually overlooked at times. So then general examination is very important. Excluding drugs effects means sensitivity to anticholinergic drugs, Evidences says all of us give quetiapine in some doses in this, but quetiapine in comparison to clozapine was better. Clozapine is far better, and now as we all are using, probably have started using the US FDA approved treatment with pimavanserin, the only drug that is being approved for this particular purpose. Apathy occurs with almost half of these patients, overlap with depression and cognitive symptoms, and it is found that people who goes to were treated probably with deep brain stimulations, apathy worsens post deep brain stimulation, where medication changes are not done, medications are reduced, so decrease in dopamine agonist use post-operatively. In those cases, apathy seems to be more prominent. SSRIs are also used. We should be cautious because it can worsen apathy. Evidences are for pyrimidine and rivastigmine. S2 please. So core components of CBT such as exercise and behavioral activations have been associated with significant improvements. Cognitive impairment, we all know, it is there or the part of the illness as a later phase of this. Predictors are the old age or age at the disease onset, greater disease severity, and all these we have seen. Management is mostly with anticholinergic inhibitors. Stimulation therapies in cognitive impairment of PDs are transcranial direct current stimulation that has been found to be efficacious, not alone but with cognitive training, RTMS, and intermittent theta stimulations. Other non-pharmacological treatments for cognitive impairments are aerobic exercises with recumbent ergometer, virtual reality training, computerized working memory training. So people have come with softwares nowadays, for dealing with these issues. So going this last slide probably about impulse control disorder and related behaviors. The impulse control disorders, we know that compulsive gambling, shopping, frequently we found sexual behavior or compulsive eating behaviors in these patients. Dopamine dysregulation syndrome, compulsive feeding medication use, affective dysregulation of altered decision finding, and repetitive non-goal directed activity, that is funding, is found in these illnesses. Many of them, 1/3 of them have multiple ICDs. Dopamine agonist treatment is the strongest ICD predictor, and TDS is associated with high level overdose. How you treat? No specific drug, but naltrexone has weak evidence with some efficacy, and otherwise you titrate the molecules. So take home message: neuropsychiatric symptoms are common in Parkinson's disease. Neuropsychiatric symptoms remain under-recognized and under-treated, often leading to adverse outcomes. And it has a significant neurobiological basis. And throughout this course of the illness, it is important to recognize and its presentations, psychotropic medications, psychotherapeutic techniques, stimulation therapies, and other non-pharmacological treatments are used clinically. So a multidisciplinary approach is important for comprehensive treatment of this. Future research are important, focusing on novel ways to treat this problem. Thank you.
Thank you, sir, for excellent presentation. So this is a very important topic nowadays. In our busy OPD, when a patient comes, Parkinson's patients come, we are very concentrated on the motor symptoms. Even the patient will also complain, I have issues with the gait, I have issues with the rigidity, I have issues with the tremulousness. And we also, because the OPD is so busy, we find it very difficult, or we do not ask about the psychiatric symptoms, whether you are suffering from depression, anxiety. But this is also very important. We need to ask about these symptoms also, and this can increase, this can make their life better. This definitely can improve the non-motor symptoms. So the discussion is open for questions. Anyone can ask questions.
Thank you, sir, for your nice presentation. I have one query, sir. You have mentioned the venlafaxine for the treatment of depression. But as far as I know, venlafaxine has a common side, it's a serious side effect of memory loss. So, should he go for that? That's preferable or not? I don't know. That's why I'm asking you.
What I mentioned here is that on the basis of available evidences, available publications that has been done, no? There are probably all the antidepressants have been tested. So on the meta-analysis, when you cumulate the samples, you find that when you measure the depressive symptoms with particular scales, how it has changed over time with treatment, then probably where venlafaxine shows some improvements. Yes, definitely venlafaxine has its own side effect profiles, from cardiac to is a high rise of BP and all these things you cannot give. So that's why probably I also mentioned if it is not contraindicated. So if it is contraindicated, definitely you cannot give. But if you consider the depressive symptom per se and you measure it before applying the medication and post applying the medication, on those scales it has shown significant statistical improvement. That's why I mentioned that probably the evidence is on these molecules.
Thank you, sir.
Sir, I have two questions. First of all, like pharmacotherapy we can use, no doubt. So how is your experience, the non-pharmacotherapy, like CBD you were saying, biofeedback. So how efficacious this, sir? Do you think that each and every patient will need pharmacotherapy or SSRIs and SNRIs? Or without SNRIs, SSRIs also we can manage these patients? And what is your experience?
Definitely, my experience is that we mostly use molecules. Number one thing that we don't have enough of these resources to use. We don't have, maybe fully equipped ourselves to do CBT, or probably don't have time for that. And definitely refer to our colleagues who are doing this. But yes, now in presentations like these, when you go via the evidences, people who are doing this in proper way, we take reference from there. But yes, when it is done, CBT is done properly, at least for mild to moderate kind of symptoms, it definitely works. And that now we have evidences of that receptor level changing also with a proper CBT over time. So, but my experience is that as you are busy with the OPD in this kind of patients, hardly we do ourselves. But yes, when you at least not full-fledged CBT, but at least certain supportive psychotherapy also works, not only for the patient, but it also has a significant caregiver burden. A person with Parkinson's disease in a family, over the years, the nuclear families, how to manage, all the time you need a caretaker and all these. Families are also overburdened. So at least what we call as family therapy, wherever feasible, how to address their emotional issues. So some input or counseling about of the attendants are also important. And also probably limiting their expectations and probable cause of illness, that you should be future ready for this. This is the likely situation is going to be like this. So these are the ways at best we can do in our day-to-day clinical practice, but properly exact ways of CBD myself I don't do. I used to be at Guwahati Medical College. We used to do with our colleagues, few of the patients. I would say only few of the patients that we encountered. Thank you.
One more thing. So pimavanserin is a new molecule. So this is indicated only for hallucination or delusions till now, not for frank psychosis.
Yes.
This is US FDA, what they say. So how's your experience with this drug? Because I'm hardly prescribed till now. So I am particularly still using Kutipin, which is every neurologist the darling molecule for every neurologist.
One thing there about pimavanserin, although it is really now in market and all of us are probably finding patients to treat it. So it is mentioned that you treat those specific symptoms of disease, PD with psychosis, but probably not PD with dementia and psychosis. So people where hallucinations, delusions or psychosis maybe is a part of dementive process, probably pimavanserin is not advisable there, and they have mentioned in literature also. So it is specifically for psychosis before developing your cognitive symptoms. So 2-3 cases I have used, probably that postural instability or that sedation kind of things are probably a little better. That initially that we can say on the very early days of that.
Thank you for the precise and to the point presentation, sir. And regarding the CBT, sir, practically it becomes very difficult considering the age of the patient and when cognitive problem has already started. So patient cannot follow those tasks or whatever cognitive errors we are trying to correct, the patient is going to forget it. So practically it is not that useful, sir. Thank you, sir.
Comment regarding the psychiatric symptoms. Nowadays it is very important also to evaluate, because for DBS, to decide candidacy for DBS, you need to evaluate the patient for psychiatric symptoms. Because if you are performing a STM DBS, like subthermic nucleus DBS, that this patient is going to worsen after DBS. So that is also one point I want to mention.
After DBS,
yeah. After DBS, if your target is STM, subthalamic nucleus, not the GPI, this patient is going to worsen. Even they are going to try for suicidal tendency. They will have suicidal tendency.
There is a study probably where GPI is more far better.
GPI is far better if the patient already have a depression, like moderate to severe depression, we have some suicidal ideation. So that patient you should not put for a STM DBS. So if still patient wants DBS, so you can give an option for GPI for those patients.
Because I was asking whether you are trying somewhere in some patients, not maybe for Parkinson's disease, whether we are doing here deep brain stimulations.
Don't think so. We are doing it till now. Okay. So any questions? So if no questions, we can wind up this session. Thank you, sir, for your very presentation.
Thank you.
Hello. Thank you, Dr. Sir. I would like to request Dr. Priyanka Bhattacharya, our clinical psychologist, to come and offer a token of respect to Dr. Upada sir. I request my colleague to please bring the... I also request next speaker, Dr. Riken Kolita, to be prepared with his presentations.
Thank you to the chairperson. To chair the next session, I would like to invite Dr. Aparanjita Barman, neurologist JNRC, Dr. Kasri Bhagawati, consultant emergency Apollo Hospital Guwahati, and Dr. Prasenjit Gogoi, consultant emergency Apollo Hospital Guwahati. I request Ms. Angelis to kindly welcome them. Now let's hear from emergency perspective on how to manage head injury in children from Dr. Riken Kolita, Associate Consultant Emergency Apollo Hospital Guwahati.
Respected chair and my senior doctors, my teachers and my friends. So today I am here to talk a little bit about head injury in children and how we in the emergency basically approach and try to manage the head injury in children. Basically, as all of us know, that head injury is one of the leading cause of mortality and mortality in children in traumatic brain injury. It gives us challenge in emergency that children have different anatomical and physiological variations compared to the adults, and also there is a challenge in evaluating the neurosurgical or neurological perspective in a children. As I have said that children brain is different than the adult. We know that in a children, the brain doubles when he turns into 6 months of age, and it reaches around 80% of the brain volume when it is around 2 years of age. Cerebral brain circulation also increases, and it reaches doubles when it is around 5 years of age, and accordingly it regrets. So we have to take lots of considerations when we are going to deal with a child which is having a head trauma. So in my presentation, I'd like to go and try to put emphasis on these following topics. What are the major differences compared to the adults? Most common causes of the head injury in the children. What are the types of head injury we generally encountered in the emergency? They are presenting signs and symptoms. Clinical decision-making criteria for CT scan head, when to do, when not to do, and our emergency approach and the management part. So as I have said, there is a lots of anatomical and physiological variations when child is presenting to the emergency. We must need to understand why children are different from the adults. Before that, talking into the traumatic brain injury, if somebody says to us that head injury, the common thing comes into our mind is injury to head. So injury to head means there might be an injury to the skull or inner structures of the brain. That might be brain parenchyma or neurons or anything else. So according to that, we have derived a GCS score, and according to GCS score, we try to divide them in mild, moderate or severe type of head injury as part of GCS. So as GCS 14 to 15 we take as a mild traumatic head injury, from 9 to 13 we take as a moderate, and if it is a less than 9, we take it as a severe traumatic head injury. So before understanding about child's head, we need to take consideration why children are not little adults. We cannot take them as a miniature of adults. The stated points are, their heads are proportionally bigger to the rest of their body. That means they are more likely to hit on head when there is a injury or fall. The subarachnoid space is thinner, meaning there is a less cushioning effect, so less shock will be absorbed. The cranial sutures don't fully close until 12 to 18 months. So in young children, there is an increased tolerance for expanding intracranial content. That is, hematomas might be edemas all, which can be go unrecognized. So until unless they don't show a major signs of deterioration or a rapid deterioration, we might miss the head injury part in a children. The unfused cranial sutures also mean a large volume of blood can collect intracranially, may can lead to hypovolemic shock. Young children can have up to twice the cerebral blood flow. Again, if blood flow is compromised due to raise in their intracranial pressure, they might be suspected to hypoxia and hypercapnia, which is not good for them. And children are more likely to vomit after following a head injury, regardless of their intracranial pressure. However, persistent vomiting or vomiting that becomes more frequent is a concern, and that mandates to do a CT scan of head. So these are the considerations we definitely has to take in account when we are dealing with children. Now talking about most common causes of child how they are going to get a head injury. So most common cause is the fall. Now we need to understand that when a child falls, it falls is a little bit different than the adults because of the proportionality. So by the word proportionality, I want to mean that their height is less proportionate to their head length or head weight. So, and they have less developed ligaments in the cervical spine. So when they fall, their head hits the ground first, leading to head injury. Secondly, their height is less. So whenever they fall, their fall is rapid. And they don't fall like in a projectile motion. They fall and they tends to roll. So their fall, basically, one fall is collective of very small, added of small falls. That is good for the child basically because the mechanism of injuries get absorbed. But if head is stuck first and head is higher than the body, then impact of injury is higher. Secondly, young childs are energetic and most of the time they have engaged with outdoor activities, sports activities, recreational activities. So they tends to get injury. So in the picture you can see they are playing footballs, they are doing gymnastics, and they are also very curious about learning new things, how to ride a bicycle, how to drive a scooter. So during doing this type of events, if they are not properly supervised, they might get head injury. Motor vehicle accidents. If child is placed in a small car or small bus driving, the car crashes, adult may be able to do little bit of their safety measures, but in child it is difficult for them. Also, if they drive in a small cycle or bicycle, due to their nature, not able to maintain proper position or posture, they might hit to another car. Though today's car and bikes are more safe and they have safety features like child seats, but they are still very high risk of having head injury during a motor vehicle crash. And one more thing we must say that there is also a point of abusive head trauma. So if mechanism of head injury is very not clear, then we have to carefully consider of diagnosis of child abuse, which is previously also called non-accidental injury or second baby syndrome. So mechanism of injury might be direct impact to the head, or there might be a second or combination of both. So if a child comes with multiple injury in multiple locations with different stages of healing, there is a retinal hemorrhage. If we do a CT scan, it shows a bilateral subdural hemorrhage and significant neurologic injury with minimal signs of external trauma. We should always suspect a non-accidental injury or abusive head trauma. There might be also indications if parents are taking medical help in delayed state or different persons of the home giving different form of history that how child get fall down, there it raises a suspicion of abusive head trauma. So most common head injury we can expect in a child after fall is a concussion, because I have already explained that child head is larger proportionally with the body and their ligaments of the neck are not that much of developed, muscles are not that much of developed, so they are not able to hold it and they might get to impact over the ground or anything. So concussion is a thing that once the child head hits somewhere, in initial stage there might not be a visible blood inside the brain in the CT scan or something, but child might have brief loss of consciousness. So it may ranges from the minutes to the days. So it is a clinical sign and symptoms that reflects functional disturbances rather than a gross structural abnormality. Contusion is a small hemorrhagic spots inside the brain. But the bad thing about the contusion is they can get bigger with time, leading to the clinical deterioration of the child. Skull fracture means if skull got fractured with a blow or after the fall and it's open up, sometimes maybe exteriorly. And intracranial bleed. So there are various type of intracranial bleed you can expect in a child with a head trauma, extradural hemorrhage, subdural hemorrhage, SH, or intracerebral hematomas. So once these things may be available in the city, once presenting the child into the emergency, so what are the presenting symptoms we might expect from the child? So there are mainly 5 or 6 presenting symptoms. So loss of consciousness, there might be a headache or vomiting, signs of basal skull fracture, ENT bleed, and there might be seizure on presentation or after presentation in the emergency. So signs of basal skull fracture are mainly hemotympanum, panda or aconitis. Those are egomatic patches around the eyes. CSF leak from the ear or nose, and battle signs. Those are bruising over the mastoid or postauricular area. That might significant basal skull fracture, or there might be a fracture of the petrous part of the temporal bone. So most challenging part is once child comes to the emergency, we have to do a general assessment of the child. So once child arrives in the emergency, definitely child is very upset and very scary, as long as the parents also. So we have to do a very calm and friendly approach to calm down the child and calm down the relative, and accordingly we have to do the approach. So idea is if child is awake, then we should make an arrangement that the child can see their parents, or if parents can comfort the child with a helping hand or sitting nearby, then they can make the child come easily, because they are the parents, they know how to do it better than us. Secondly, if situation demands that child needs some sort of resuscitation and parents should not be stand in that position, then we should give our hospital staff to attend the parents to talking, and they can calm down the parents accordingly, so that we can address the child's clinical condition. So approach is always ABCDE. Airway comes always first to protect the airway. Breathing, airway, along with the airway we have to check for the breathing and all. For the circulation, if child is hypotensive, then it is more prone for hypoxia because of hypovolemic state. There is a lost blood going to the brain, and there will be a prone for secondary brain injury. So adequate volume resuscitation should be there. Then we will to assess for deformity, disability by doing a GCS score, and exposure from the head to toes. That comes from head, shoulder, knees and toes. It's a good approach. So GCS assessment child is almost same as adult, but less than 4 years there is a modification in the verbal part. So we have included this slide. The verbal part is little bit modified because those people cannot reply or respond like an adult. So criteria for CT scan of head. So clinical decision rules. These 4 are clinical decision rules are developed many times to help the emergency physicians to guide them when to do a CT scan and how to avoid CT scan CT scan related long-term complications. Mostly we have used in emergency, those are pediatric emergency care, applied research network, that is PICAN rule, and NICE guideline rules. So beauty of the PICAN rule is it directs for children, those are younger than 2 years, and also those are older than 2 years. So they have basic differences. They have included headache and vomiting in both the slides. And the goal is to identify patients at very low risk of intracranial injury who do not need a CT scan. So all predictive variables are negative, no CT scan is required as per the PICAN rules. Also, to support the evidence, we have NICE guidelines. They have specific sets of signs and symptoms, and accordingly we can follow so that we can decide that child needs a CT scan or not. So those guidelines are available in website and NICE RCAM learning. So in the management parts, we coming to the drugs to lower the intracranial pressure. Generally, we use 3% normal saline or mannitol. Seizure prophylaxis, basically we give mainly in 3 situations, where if there is a depressed skull fracture, or if child is taking anti-epileptic medications previously, or the child if presents with active seizure, or if there are any intracranial hemorrhage. If there is increase in signs of increased ICP, then ICP monitoring device should be put, and the child should be admitted in the PICU. For resuscitation drugs in emergency, we have IV fluids, we have antibiotics, blood products, and suturing of minor and major wounds can be taken into the consideration. So also we have to look for the safeguarding issues because of non-accidental injuries. So we have a duty to care of the older children and consider possibility of non-accidental injury in children. Along with that, we may involve our social services or government services if there is a possibility of non-accidental injury in the child. So with concluding that, I must say that head injury in the children, managing in the emergency is a challenge, but the goal is maintaining the normothermia, normocapnia and normoglycemia. This is the main goal, and we have to be innovative and little bit exploratory to management the head injury in the child in the emergency. Thank you.
Thank you, Dr. Megan, for your nice presentation. You have covered everything, but I think children are our future, so we have to protect the children. And one more thing I want to know: how much seizure is frequent in post-traumatic seizure in case of children? In case of post-traumatic brain injury for children, seizures are how frequent? Seizure, do you come across? Seizure.
Post-traumatic brain injury.
Yeah, for the children.
I have already said we have given post-traumatic. If there is a 4 factors, like we have given prophylactic anti-epileptic to prevent the post-traumatic seizures. If there is a depressed skull fracture, or if there is a intracranial hemorrhage, or if the child is taking previously anti-epileptic drugs, or if child is present with a seizure episodes, then these episodes, in these options, we have to give anti-epileptic drug to prevent that post-traumatic seizures. If we are not given, then probably it's definitely likely to have post-traumatic seizures. I cannot say exact the percentage, ma'am, right now, but yes, definitely there is a possibility.
One more thing I want to know: what are the major complications following in case of children? What are the major complications in case after traumatic brain injury? I mean, cognitive impairment, all this, how common? Cognitive impairment is how much common?
It depends upon the severity of the brain injury, basically. As per we know that we have classified it mild, moderate, or severe. If it is very severe, then there is a high chance of mortality and morbidity, as per the literature says. But yes, definitely, whatever we have evaluated, and as per the CT scan and all, there is a possibility of cognitive function deteriorations. So for that, probably child needs a speech therapy or behavioral therapy, and all these things definitely has to be given.
Thank you. I'll hand over.
So Dr. Regan, nicely you have presented. A good presentation, but ma'am, I would like to answer here. Most of the head injury cases that we encounter in our emergencies, 80% of cases are mild traumatic head injuries. So the complications which are seen only in case of severe head injury, so are less. And your question about seizure presentation, so they're very less compared to, because 80% of our cases are mild head injury. I would like to mention about Dr. Regan, you have told about the city guidelines scoring. So what are the latest take-home message about because it's very important, we don't expose them for radiation, right? So we always observe. So 2 hours, 4 hours observation. So can you highlight on that nice guideline? regarding how much we can wait regarding depending upon their scoring.
Thank you, ma'am. Thank you, ma'am, for the question. Basically, this is the nice guideline. What distinctly says that what to do if child plus head injury and CT has to be done in 1 hour. And if child plus head injury and one of more these factors, you can wait for some time. So in the right side, you can see there is a loss of consciousness more than 5 minutes weakness. But if there is only one factor is present, then definitely it's in the last line it is written, if only one of these risk factors, observe minimum of 4 hours from the time of injury and do a CTF. If they continues to vomiting or child GCS get deteriorated, then accordingly we have to evaluate and accordingly we have to act.
Any questions from the audience?
Thanks, Dr. Kolita. This is a very important topic actually. Most of our trauma, even in neurotrauma, most of the time we neglect about the pediatrics group of head injury. Yes, pediatric head injury is not that same as adult head injury. In adult head injury, we take 1 hour is a golden period of time. But in pediatric age group, we should take the baby as early as possible. And most important, most of the time, the baby gets deteriorated because of enormous amount of scalp hematoma. Because in pediatric age group, that gallia is very loose. So even a slight fall, there is a tendency to have large amount of subgaleal hematoma, and most of the time we neglect it because the blood volume is very less. If suppose there are 50 ml of blood loss in the subgaleal region, that may leads to the baby may come back with a shock. Second important factor is why most of the baby get deteriorated, because early set in ABCD management is very important. Because hypoxic damage of the brain is very sensitive in case of pediatric age group. So these are the two important criteria that we must always follow in pediatric age group. And third important point is any baby came with a head injury, irrespective of severity of any type of dangerous mode of injury, anything. We should keep the baby for observation for at least 24 hours. That should be mentioned to the bystander. So these are the very important few points I just want to add to you.
Thank you, sir. Thank you.
Thank you for your good presentation. Whatever it may be, to predict the case of head injury in children is not a very easy. According to him also, you should wait for at least 1 hour. My question is there any judicious use of mannitol? It is seen that in every hospital using mannitol after coming a case of head injury, we are using mannitol. Is there any dose or is there any criteria to use mannitol?
Basically, in children, hypertonic saline is more preferred than mannitol. But dose is around 1 gram per kg we have used. But hypertonic literature says that hypertonic 3% saline is more useful than the mannitol.
Sorry to interrupt. We're getting late. Can you just go for the next sessions? Nobody minds. We can carry on a discussion in the dinner time. Sorry. And requesting the next speaker to let us keep only one question in the next session so that we can skip, because already we are 1 hour late.
Okay. Thank you, sir.
Regent sir would like to give you a token of love.
Moving on to the next session, I would like to invite Dr. Ajit Goswami, Senior Neuropsychiatrist, Saints Hospital, Nagaon, to chair the next session. I would like to request Angelis to kindly welcome sir with Fulam Kamusam and a memento. I take the privilege to invite on stage Dr. Surajit Barwa, Director Medical Service, Apollo Hospital, Guwahati, to talk on the topic medical legal aspect for clinicians.
I wanted to start the session with a good afternoon, but it's already good evening. So we are exactly 1 hour behind schedule. I won't take much of time. First and foremost, I'm Dr. Surajit Barua. I'm privileged to be acting as the Medical Director of Apollo Hospitals, Guwahati, Unit International. And I take the privilege of welcoming all of you to this wonderful evening, where we see a cross-section of specialists from across the government sector, the corporate sector, as well as the private sector. Your stalwarts in the practice of medicine, neurosciences, getting together under one roof is indeed wonderful to hear to your deliberations. My topic is a little aberration from the normal flow, because I want to just share with you a few tidbits of the importance of the medical legal aspects in our daily practice. But I'll first make a disclaimer. I am not a lawyer. I'm just a doctor like you. I'm running a hospital. But there are certain aspects that come to us on a daily basis regarding the practice, litigations of the consultants, where we have to sit across the table first, draft an answer, draft a proposal, and then perhaps seek the help of our lawyers. So, with your permission, I will just share with you a few of the important essences of the legal system in India, which we as clinicians should be aware of. The statutory authority of medical education, as we all know, previously the MCI, currently is NMC. And the laws that directly govern the professional code of conduct of doctors, there are 10 laws. Most of us are not even aware. And today, because of time constraint, I will just highlight the one most important law that pervades and prevails over us, that is the Indian Medical Council Professional Conduct, Etiquette and Ethics Regulations 2020. The laws directly governing establishment, that is the clinical establishment where we work as clinicians, there are 106 laws. The laws empowering the patient as a consumer, of which we are so worried, is just 2 laws. And then they can steal our happiness forever. The laws of the licenses in a hospital. There are around 67 licenses we need that needs to be upgraded on a yearly basis, bi-yearly basis, 5-yearly basis to keep the operation of the hospital running. Now, to give you a small perspective of the law, why are we doctors so scared of the law? There is a term that is coined specifically for us Indian doctors, that is ignorantia juris non excusabile. That means we don't know. I was not aware of this. That excuse we cannot give in a court of law when we are accused. So if the prosecutor or the judge question us in a court of law, okay, Dr. Sahab, why did you do this? Were you not well informed? And if you say that I was not aware, then the court will not allow that excuse to you. Which means we have to have a little insight of what we do. Now, what are our fears and apprehensions? First, we don't want to go to the court. Even if we are called as an expert witness, we doctors don't want to go to the court. Next is penalized by compensation or term sentence. This is another threat. It ruins our lives, our profession, our families, everything. Debarred from practice. What can be more embarrassing or shameful if we as clinicians are debarred from practice by the state commission or even by a jurisdiction? Suspension or termination from service from the institute where we are working. So these are the shared fears which we all have. Going ahead now, people are taking the law into their own hands. It is very difficult to bring the bad news to the patient party.
They may not accept it. They will come and just beat up the doctor. But my essence is not to frighten you. My essence is to share with you that all is not dark and gloomy. The law of the land, that is in India, gives us to some extent a protective leverage over the average citizen when it comes to litigations on it. So there is a saying that no doctor knows everything. That's why it is called practicing medicine. But what are the first steps that we need to do in our day-to-day practice? The primum non nocere is a Latin terminology which says that first, please do not do any harm. That is the first concept of us being able to run through in our day-to-day practice. Duty of care in deciding whether to undertake the case, duty of care in deciding what treatment to give, and a duty of care in the administration of the treatment given. These are the broad guidelines that should take in our minds when we are taking up a case. Now, another thing that we often hear in the news, the Consumer Protection Act, that a doctor has to attend a patient in emergency. Do we really have to? Then again, there is some news coming up that a doctor can choose his patients. I will choose which patients to treat. I will refuse treatment to certain category of patients. But this is a dilemma for us. What do we do? In short, please remember that the Supreme Court states that if we are qualified doctors, licensed medical practitioners, then according to the emergency healthcare laws, we have to respond to an emergency situation. If you respond to an emergency situation, it will be taken as a doctor doing something in good faith. But if we are trained, we are present in that scenario, and the law finds that the doctor did not do anything or did not intervene, then somebody can point a finger at us. COPA, Consumer Protection Act. When this came into force, the first change in our society that came is that our fate was sealed that healthcare is no longer a service, healthcare is an industry. It is a consumerist industry in which people are willing to pay. We have the right to charge a fees. We have to give a bill. And on top of that, if we are wrong, then the law can sue us if the patient goes to the consumer law. So in this case, the importance from our side is that communication should be free flow. We cannot withhold any communication from the patient party. The option for a second opinion, we should not be egotistic if the patient party says, Doctor, I want a second opinion. You cannot say, why you don't have any trust in me? Rather, you should welcome that please go ahead, have a second opinion. In hospital settings, we arrange for a second opinion as per the choice of the patient.
stimulation is needed. The reason each day patient remains on ventilator, there is 6% reduction in the diaphragmatic thickness and diaphragmatic function. It's a proven fact. Although little better in children, it is only 3.5% reduction, but in adults it is 6%. So diaphragmatic stimulation, we'll discuss that. Then pacing. Unfortunately, pacing is very costly. It comes in a range of 10 to 30 lakhs, and most of the patients in India won't be affording this. What is feasible is what I will be discussing is phrenic neurotization. So denervation with, as I said, each day will lose 6% of diaphragmatic contraction thickness fraction and excursion as well. So we need to monitor and choose patients, especially in the first 4 to 6 weeks, who will require pacing and neurotization if needed. This is a very effective and very cheap procedure which can be done bedside, and transcutaneous muscle stimulation prevents the motor end plate degeneration, and that has been established for skeletal muscles and also holds good for diaphragmatic paralysis as well. So in this study which I quoted in the last slide, about 1.77 times improvement has been documented over a period of 6 months in this particular case study in transcutaneous electrical diaphragmatic stimulation as compared to standard pinning procedures. Then the diaphragmatic pacing. Diaphragmatic pacemakers are usually transvenous, trans-IVC pacemakers are available by Boston Scientific as well as Medtronic. But the cost is prohibitive. For Boston Scientific, it costs around 30 to 40 lakhs, and that is a rechargeable battery. Whereas for Medtronic, we can use the DBS, common DBS implantable devices, but that has to be put topically over the phrenic nerve through a cervical exposure. But again, that cost can be prohibitive. So the answer to our scenario is the spinal accessory to phrenic nerve transfer. We'll discuss, as with the case I will discuss, which cases to choose and how to choose. Although we have very short experience of this. And the quadriplegic, I will state this is everyone knows about this. So I will straightforward go to my case. An 8-year-old boy came from a remote village of Nagaland, presented to our emergency with respiratory failure. The ETCO2 was 105, patient had respiratory arrest. Patient was E1, M1, B1, was intubated. Was taken, he had an MRI. He was sent with an MRI which showed osauditorium with high cervical cord ventilation. There was, obviously this CT also shows an osauditorium with significant canal compromise. So we took for an emergency procedure as expected. We did a C1, C2 fixation. Post of day 1, thankfully eye opening improved, but only some nystagmus, downbeat nystagmus was there. Patient remained quadriplegic 0/5 power. No spontaneous respiratory efforts. 3 days later, right upper limb started moving. Lower limb remained 0/5. Left upper limb 0/5. 4 weeks post-op. All throughout this period, patient had complete respiratory failure and no spontaneous breath efforts so far. But some on CPAP mode, we used to continuously monitor this patient every day with bedside ultrasonography and diaphragmatic thickness fraction monitoring, excursion monitoring. And the thickness fraction was low, and the fraction was less than 0.1, and the excursion was about 1 millimeter, 2 millimeter, hardly any excursion at all. So we X-ray showed persistent left diaphragmatic paralysis. You can see the left diaphragm is elevated. So we thought, let's try and do something for this. So we took for a phrenic nerve neurotization 5 weeks post surgery. So we did a left spinal accessory to phrenic nerve. How we do it? Regular supraclavicular exposure, identification of the spinal accessory using intraoperative stimulation, and then anastomosing end to side. This we do with a 10-0 or 11-0 polyamide or nylon sutures. We had started this transcutaneous diaphragmatic stimulation from second week post-op, so as to reduce the ongoing diaphragmatic atrophy. 16 weeks to 18 weeks post-op, patient had improvement in the left diaphragmatic paralysis. By that time, patient could be weaned off for 1 hour every day. Gradually, we improve. And eventually, you can see the pre and post, the left diaphragmatic paralysis improve. This patient, 18 to 20 weeks post-op, could be put off ventilator for 4 to 6 hours. Now the next problem was patient could not sit without support. We did erector, this also we had started from 3rd week post-op, erector spinal stimulation, so that the patient doesn't have that develop worsening of kyphosis and loss of tone. So then the patient could gradually sit without support after 24-26 weeks after first surgery. Then the problem was we did a spinal axis schizophrenic nerve transfer, but spinal axis nerve will not help in cuff reflex. So cuff reflex was always a problem. Patient had poor pulmonary toileting related pneumonitis which had to be taken care of. Then dysautonomia. Patient had to be on midodrine because patient used to develop hypertension whenever we used to make the patient stand with support or with the help of this aid. So then patient eventually after 6 months of aggressive management could be able to be discharged. And finally, 7 months post-op, patient could vocalize. So this is what my presentation was. The role of phrenic nerve neurotization in case of diaphragmatic paralysis and type 2 respiratory failure and patients with quadriplegia. So it's a very feasible, almost no money needed for this neurotization procedure. Apart from small, little bit 2,0 Vicryl is all is needed, nothing, no more cost, and 10,0 ethanol. And it is timing. As I said, 6% per day. So you have to be agile. You have to choose cases. You have to choose cases which have shown that there is a reduced diaphragmatic thickness fraction. You have to see diaphragmatic thickness daily and compare, have a flow chart of that, and so have to have a graph of that. If there is a progressive decline in the diaphragmatic thickness, it has to be done within 4 to 6 weeks is what our early experience of 3 cases. Last 2 cases have been done at SCPJ, shall not present in those. So this is what the presentation is. Thank you.
Very nice presentation, Dr. Dixit. Is there a question from the audience?
I saw Majid Sami once when he was doing nerve grafting, and he used to do analysis of the facial nerve because of his CP tumors. So he used to use super glue or that quick glue instead of stitching. Have you tried doing that?
Sir, we do both. In this case, we didn't use a glue, but in usually peripheral nerve surgeries, we use both suturing as well as glue. Just glue usually doesn't suffice, especially in brachial plexus injuries, which I'm referring to, because we include active range of motion exercises very frequently 1 week post-op. So we always have fear that the glue may give up. In this case, we could have tried that, but financial constraints, so we used only ethylene, and that was good enough.
Very nice presentation, Dr. Dixit. This case result is very encouraging. So you're talking about other 2 cases, right? You had 3 cases. So what were the ages of those 2
Sir,
patients?
the last 2 cases were of traumatic cervical spine injury. One of the patient expired due to MOTS, and we had bed sore also. Although there was some improvement in diaphragmatic function, that was the first case which we did. He died of MOTS after 3 to 4 weeks. The second patient had unilateral diaphragmatic paralysis, who improved, and this was the second case. The second case was 17-year-old boy who had a C3, C4 injury. The first case was a C4, C5, C5, C6 injury. I vaguely remember that patient had expired.
So what was the age of that patient?
Both were less than 30 years. One was 17 years, as I told. The other one was, I think, 20s. He was in his 20s. This child was 9-year-old. Possibly the young age is...
That's what yeah. In younger patient, I think this should be done in this kind of cases,
Yes.
but as we ages, I think...
It will be difficult.
Yeah,
Moreover,
it will be
sir,
difficult.
the distance from the anastomotic site to the diaphragm also matters. In adults, it will be at least 60-70 centimeters, and that will take about 3-4 months. That will take about 10-11 months to neurotize, whereas in children it will be easier. The distance also is lesser.
Very good job.
Thank you, Dr. Dixit, for your nice presentation. So, can you elaborate more about indications and selection of case?
Case selection, sir.
Yeah, case selection and what are the indications?
Sir, high cervical injuries only is what we have experienced. Unilateral diaphragmatic paralysis, usage of spinal accessory to phrenic is a known procedure, especially due to an iatrogenic injury, for example. So that is a known indication. But in high cervical injuries, we may expect a spontaneous recovery as well. So it's very early experience, but what we propose is only 4 weeks we have to wait, and we have to keep on continuously monitoring the thickness fraction. There's an ultrasound which is immediate, and we also see the diaphragmatic thickness and excursion. If there is no improvement for 4 weeks, it is better to go for end-to-side anastomosis. And we use only one fascicle of spinal accessory now. Spinal accessory has about 3,000 to 4,000 motor units, whereas in diaphragm, for phrenic nerve we need hardly 900 motor units. So one fascicle of the spinal accessory is enough to, so you're not losing anything.
So there is no chances of spinal accessory paralysis.
Sir, that's what, we are using only one paralysis. We often use spinal accessory to suprascapular anastomosis for brachial plexus. That's a very common procedure. So there also we don't see significant shoulder droop. So here anyway the indication is more important than the spinal accessory function. And being an accessory muscle of respiration, it synchronizes very well with respiratory movements. So that's why we go with the accessories.
Okay, thank you. Any question from the audience? Okay, thank you, Dr. Rich.
Thank you, Dr. Priyadarshi Dixit, sir, for the wonderful presentation on your success story. Request our team to present the token of appreciation. I hope the technical glitch is clear now. Okay. So now I would like to request Dr. Tamajyoti Ghosh, if you are ready with the presentation, to kindly come up on stage. I would like to call upon Dr. Bayakamenlang Sinmon, Dr. Ram Goyal, and Dr. Asman Ali to kindly chair this session on neuroendoscopy and its application. Requesting the team to kindly welcome our chairpersons. So we can start the presentation.
Good evening, everybody. Sorry for the delay. There were technical glitch going on. So I will be speaking basically about neuroendoscopy and its application in neurosurgery. Now, neuroendoscopy is not an newer subject. First, initial neuroendoscopy was done in 1922 by Dandy. He did the third ventriculostomy, but the most important, breakthrough in the neuroendoscopy came recently in 1969 by the invention of the computer-coupled device, which is basically a chip which transforms the images to the visual images to the computer screen. So the neuroendoscopy basically is based on the principle of total internal reflection. Now, the light source is at a distance because getting a strong light source near the neural tissue can be quite harmful. So we need a light source which has to be placed at a distance, and the light has to be transferred through the fiber optic to the near the tissue for illumination. So basically, what is required in this thing is the principle of total internal reflection. Now, the components of endoscope, the endoscope basically contains a rigid or flexible tube, a light source, an objective, an image guide, an eyepiece, and other additional channels. So there are two types of endoscope. First is the flexible endoscope, which is also called as ventriculoscope. Now, the diameter ranges generally from 1 to 15 mm. The advantage of this endoscope is that you can negotiate into tight spaces, and what is one of the most important drawback of this endoscope is that the lifetime of this endoscope is quite less if you compare it with the rigid endoscope. Now, the rigid endoscope has one more advantage if you compare with the flexible endoscope, that we can add more working channels as much as we can required. One for grasping the tissue, one for suction port, one for irrigation. Now, this is an operating endoscope with two working channels. We can see the two working channels out there. The light source, initially the light source was halogen, but because of the high temperature that it generates, the light source which is used nowadays is the xenon light source. The camera, it is attached to the eyepiece, and it greatly improves the endoscopic capability. So the newer advances that we see in neuroendoscope is that the 4K neuroendoscope has come. The 3D neuroendoscope, which enables the operating surgeon to have a good depth perception. Endoscope with ICG, which can be very helpful in operating cases and localizing the vasculature of the tumor. Endoscope with fluorescence for operating the gliomas. Endoscope with integrated navigation, which enables endoscopy in deep-seated lesions. Microscope integrated with endoscope. Now this Kinevo 900, it comes with a attached endoscope where we get the insect picture, you get a simultaneous feed from the microscope as well as the endoscope. Now let us discuss some cases that we have recently operated. This is a 45-year-old male patient who presented with low back ache relating to left lower limb. On examination, his power of left ankle was dorsiflexion was 4/5 and there was sensory hyperesthesia in L5 dermatome. We can see a left paracentral disc protrusion in L4/5. We did endoscopic discectomy. Here we did endoscopic discectomy by the Desdandu technique. We used the bimanual technique. The left side is used to stabilize the Desdandu port, and the right side is used as a working channel. So here we are doing the laminectomy. We are now dissecting the phlebum from the thecal sac. Once the root is identified, we will now retract the root with a lint. This Desdandu port has a port for this metallic attachment which can be used as a retractor. So we are doing the emmelotomy after confirmation of the disc space. And this is the discectomy. So we can see the incision size. Now here what I want to emphasize is that the size of the incision doesn't matter in the endoscopic discectomy. Yes, it is an added advantage, but what actually matters is that we do not cut any muscle in endoscopic discectomy. So the patient usually have faster pain relief following the surgery. This is a 50-year-old female who presented with features of acromegaly. Her visual acuity, right side was finger counting and left side was 4/6. Visual field assessment showed right-sided loss of vision in 3 quadrants and left hemitemporal anopia. We can see cellular, supracellular SOL. Now we did the transnasal transmenoid tumor excision. Now either you can hold it with your hand but bimanually, or you can use a endoscope holder for it. So once you lateralize the inferior and middle turbinate, you try to localize the sphenoid ostia. Now the sphenoid ostia is invariably located around 1.5 centimeter above the choana, posterior choana. So this is the sphenoid ostia. Once the sphenoid ostia is localized, we try to harvest the Haddard flap. While harvesting Haddard flap, you should be very careful that the upper incision should be at least 1 centimeter below the roof of the nose, otherwise the patient might lose the sense of smell. This is the vomit that we are drilling. So this is the cellar floor which is visualized. You can see the carotid impression on both sides. Now after drilling the cellar floor, so we are giving the incision in U-shaped manner. Some surgeons prefer to give incision in the true-shaped manner, but we usually prefer it to be given in a U-shaped manner because it prevents the falling of the tumor in the early part of the surgery. So you can see the tumor. We are dissecting the tumor with a ring cutter. You can see the fall of arachnoid and the pituitary gland, which can be seen, symbolizing the endpoint of dissection. Now the patient's vision improved following the surgery. Looking for any tumor adherent to the dura. This is a 11-year-old male patient who presented with headache. On doing initial CT scan, we found hydrocephalus, so we did an urgent BP shunt. Now, following it, the MRI of the patient showed a third ventricular colloid cyst. So we did endoscopic excision of the colloid cyst. We used neuro navigation for guiding us the burr and the trajectory. So we can see the ependymal lining of the ventricle. So this is the colloid cyst which can be seen. These are the two columns of the fornix. So after coagulating the capsule of the colloid cyst, we did one cystostomy and tried to suck out the colloid content. So this is the colloid content. Once the colloid content is out, the cyst wall collapses and you can tease it out by rotating movement of the forceps. Look for any bleeding point. So this is the size of the incision and this is the postoperative scan. One can appreciate the trajectory tract in the postoperative scan and there is no hydrocephalus. So this is a 14-year-old male who presented with history of headache, vomiting. He underwent transcortical endoscopic tumor resection. Now you can see one enhancing lesion in the lateral ventricle. Initially we planned to do the biopsy of the tumor, but we made this port with a 10 cc syringe. We went transcortical. So the tumor was quite vascular. You can see it is filled with lots of vessels. We tried to do the maximal self-resection in this case. Now, the biopsy of the tumor came out to be WHO grade 3 glioma. Unfortunately, we lost the patient in follow-up. This is a 38-year-old male with female with history of diminution of vision, left more than right. Visual field assessment showed bitemporal hemianopia. So we planned for an extended transnasal transphenoidal tumor excision. What we are nibbling down is the part of the plenum. So you get the anterior intercavernous sinus bleed, which can be controlled with the flow seal, as you have seen. Now the tumor was quite fibrous. We bipolared the tumor and resected it piecemeal. You can see the arachnoid, which is visible. We succeeded in removing getting a near total excision. Only a small part of the tumor adherent to the ACA was left behind because it was quite firmly adherent. This is the picture after the final hemostasis. The patient's vision improved post-surgery. This is a 54-year-old female with a history of loss of vision in right eye. She also had axial proptosis of her right eye. Visual acuity of the right side was restricted to hand movement. She underwent transnasal endoscopic tumor decompression. Now the HP of the tumor was suggestive of cavernoma. So it is quite similar to the transnasal transplantal surgery, except that we try to do a turbinectomy of the middle meatus. This is the middle meatus. This is the opening of the maxillary antrum, and you can see the ethmoidal bulla, which has been cut down. Once you cut down the ethmoidal bulla, you get the lamina peptacea. This is the lamina peptacea which has been taken out, and the anterior ethmoidal air cells which are being taken out. This is the periorbita extending to the optic canal. So once the periorbita is cut, this is the tumor which is visible. The tumor was gently teased off from the optic nerve. So, in last 1 year, we did most of the endoscopic cases were restricted to lumbar discectomy, followed by transnasal transmenudal pituitary surgery. We also did 4 cases of ETV. However, our number of cases of ETV was restricted because most of the cases of hydrocephalus we usually get in emergency, and due to logistic issue, we restrict ourselves in doing VP shunt in those cases. So concluding this presentation, endoscope and microscope should be used as a complementary tool. It should not be used as a conflicting tool to one another. In such a way, it will increase the effectiveness of microsurgical procedure. Now, neuroendoscopy has potential to further improve this neurosurgeon's surgical result and reduce the surgical risk of the patient. With endoscope-assisted microsurgery, visualization is often far superior to the maneuverability. Endoscopic neurosurgery will likely to be influenced by further innovation in the optical system, the electronical system, and integration of robotics and navigation. So, further miniaturization of device and improvement of 3D technology, multiport endoscopy will also has future scope in improving the neuroendoscopy's role in neurosurgery. Thank you.
Thank you, Dr. Tamaziti, for your insightful and thought-provoking presentation. And your expertise has given us a valuable perspective and a lot of things to reflect on. You have nicely demonstrated endoscopic, endonasal, endoscopic assisted as well as spinal surgeries. Now the floor is open for discussion. If anyone has any question.
Walk us through the complication that you have faced during all
complication. We got 2 cases of lumbar discectomy. Initial, when we were in the landing period, we got 2 cases of CSF leak following spinal surgery. 1 cases of postoperative CSF leak following transnasal surgery, pituitary microbiome, which were handled, of course. The patient did not develop any features of meningitis and all, and which was later tackled effectively.
Thank you. Good presentation. Very nice. Any questions from the audience?
I have some 1 or 2 comments only. Thank you for your presentation.
Thank you, sir.
Speaking on sitting only. The colossus invariably develop hydrocephalus because the way of presentation hydrocephalus only. So colloids, actually you are telling that before doing the colloids proper excision or doing the PPSR. Actually the hydrocephalus have some advantage for doing the surgery.
Yes, sir, definitely, sir.
So if you do the sun, it may create some problem.
Yes, sir. It causes collapse of the ventricle. So
yes,
we did the VP shunt because the patient presented to us in an acute state of hydrocephalus. I mean, he was unconscious, so we didn't have any option in the late of night to go ahead with the
That's why. Otherwise, in principle, all colloids with hydrocephalus should be done the surgery first.
Right.
Sun-dependent colloids, actually that is percentage is quite rare. Only 5-10% may be necessary post-surgery. That is one problem. And that one place I option the sphenoidal meningioma.
Plenum sphenoidal.
Plenum sphenoidal meningioma, most medial side invading the cavernous sinus.
Yes.
You have tried his best. But in my view, it is most applicable for this transcranial microscopy.
Right.
Because quite large, invading the cavernous sinus, top to the optic tunnel almost. So these two my observation. Obviously, as you have mentioned, it is not a complement. It is a complementary, not as a this thing substitute for one each other.
Yes.
Yes. Both things are available, and science are evaluating. Every day, new things comes, and it is not like that one is best for something than others. It is not like that. It is complementary, and many things to evolve in near future. Thank you for learning. You will be surgery much more smooth. Some design is occurred, but your hands will be more smooth.
Still in the learning.
Stuff. Thank you.
Thank you.
I would like to add one thing. As you saw, incision size in the spine surgery for endoscopy. Endoscopy is evolved for the spine surgery to reduce the incision, so as to reduce the muscle dissection. Incision size is more than muscle dissection is more. So now in the era of the fast track surgeries, we try to discharge the patient as early as possible and to return to the work as fast as possible. So daycare surgery is possible only because of the endoscopic surgery, because we are doing a minimal muscle dissection, only of 2 centimeter size. So that is very helpful to discharge the patient in the evening of the surgery only.
Thanks.
Thank you. Nice presentation.
Thanks.
Kindly present the token of appreciation to sir. Thank you, sir, for a wonderful speech. Our next session is on surgery of giant craniopharyngioma through multiple corridors, a video presentation. I would like to invite Dr. Amrit Saikia and Dr. Sunil Panchal for chairing the session. I'd like to invite on stage Dr. Vinay Kumar Singh for the session. Over to you, sir. Since Dr. Amrit Saikia is not here, I would like to invite Dr. B.K. Bashir sir to kindly chair the session along with Dr. Sunil Panchal.
Good evening, my teacher, professor, and good evening, teacher, my seniors and colleagues. Today I am going to present. First of all, thanks to Shaminda for organizing such an academic event. Today I am going to present surgery of giant craniopharyngioma through multiple corridors. So I'll try. Basically, it is a video presentation. So this is the scan. The patient presented with in the emergency a large tumor with a solid part more than 5 centimeters, and also the cystic part presented with hydrocephalus in the emergency. It has also a cellular component and a large supracellular component. The patient was immediately considered for the BP shunt, and the resident has did the shunt on the left side where the tumor was projecting. But still, nothing much can be done. In the NGO, the tumor was seen to enter into the multiple corridors and encase most of the vessels and compressing the chiasma. Patient also presented with blood vision. So we decided for a terminal craniotomy and excision of the tumor from vascular and optic corridors. The Sylvian fissure was opened wide, and then we opened all the systems, interoptic, opticocarotid, lateral carotid systems were opened so that the CSF can be drained and the brain becomes lax. Then we can see the tumor in the from the interoptic corridor. It was much prominent. Then we tried to shrink the tumor by devascularizing the tumor. Then we went inside and tried decompressing. We can see the contralateral ICA also. We can see the optic chiasma and the tumor and the ICA of the same side. Then we again did decompress the tumor in the opticocarotid corridor on the other side. This is how we are decompressing the tumor on the other side, the gentle section. Then we went down into the sella and with the help of ultrasonic aspirator, we tried to decompress the tumor from the sella. So this is how we are decompressing the cellular part of the tumor. You can see the carotid on the opposite side and the chiasma. So after decompressing the cellular part of the tumor, the optic chiasma was also relatively decompressed. Then we tried to decompress the tumor from the left optic nerve and the left ACA. The tumor was densely adhered to the carotid and it was not coming out with the suction and the ultrasonic aspirator. So it was relatively a bold step to do, but we should avoid doing it. We tried to dissect the tumor from the carotid itself. We were lucky enough that there was no carotid injury. Again, we are trying to decompress the tumor from the behind the left ICA by working in between both the poles, suctioning from the one corridor and trying to retrieve the tumor from the other. Then we went up and tried to decompress the superior part of the tumor, which was again compressing the chiasma. This is how we are carefully taking out the tumor with the help of biopsy forceps and gentle suctioning. This is tumor as we taken out. Then again we went and dissecting the tumor in a V-shaped manner between all the corridors of the MCA and also the ACA. The tumor was encasing the MCA and the ACA also. So further decompression was required to do from these vascular corridors. A gentle ultrasonic aspirator. Then again we came up and we had to decompress the cystic part. The internal solid part decompression has been done. Now the cystic part of the tumor is opened, cyst is opened and decompressed, and now we are again dissecting the tumor in the corridors and trying to take the cyst wall. So again now we can visualize the base of the tumor after decompressing the cystic part. And finally, we had a complete 360 dissection of the tumor for the cystic wall also, and we tried to roll the tumor to take it out from the chiasma and the vascular corridor. And finally, removing the tumor completely, gently trying to remove the tumor. And we were happy that we have done a good job and we could do total excision of the tumor. So when we did the scan, immediate post-op scan, we can see that we have done a good decompression and cellular part was also decompressed. But we can see in the CT scan there is still a residual part of the tumor still left there. We could not make out, we thought it was to be a cellular fluid. Then after 6 weeks we did the MRI and we were very demoralized to see still a part of the tumor is there and still a small cystic component is there and it was just above the pituitary. So the patient was offered stereotactic radiosurgery because the post-op patient had a stormy course, the patient has a DI and also was on hormonal support. So we decided to consider for stereotactic radiation to the patient. But the stereotactic radiosurgeon refused to give radiotherapy, telling it the optic nerve is still very close to the tumor and the radiotherapy may damage the optic nerve, causing permanent visual loss on one side. So we decided to take the patient for endoscopic guided transnasal transcanodal excision. So again we tried and entered into the cellular part of the tumor and with the help of the Gaucher debrider, the heart wave was raised. The cellar was open but mostly on the plenum sphenoid. We tried to remove much from the plenum so that we can go into the supracellular part of the tumor. So we tried to avoid going, unlikely we used to go in the lower part and decompress the tumor, but here we tried to remain on the upper part so that we should not damage the pituitary. So gently with the help of the cuvette and with the suction under visualization, we tried and decompressed the remaining part of the tumor. And the carotid was in close proximity, so we have to use probe also. The cellular reconstruction was done and heart flare was repositioned. This is how we used the microdoppler to map out the carotid because the tumor was still attached to the other side of the carotid to prevent any carotid injury. So this is the final post-op CT scan. The tumor has almost been excised. This is the final MRI. But still the patient is on DI and is on hormonal. But still doing good. The admission has been good. Thank you.
Dr. Binoy, it's good, nice to see very clean surgery. It's total excision. Still, some part is there, still in the cellular side, maybe some part is there. Radiation may be necessary. Thing is that sometimes excision of the cellular or supracellular tumor, particularly for cranial brain, radical excision or total excision may not be possible and should not be aim also all the time, because post-operatively sometimes, as you mentioned, tumor is out, but even patient have a lifelong mobility and very difficult to survive also sometimes post-operatively. So as such there is no bleeding, many patients as such there is, but there is some perforator injury and small vessel supplying the hypothalamus. If we remove this radical excision with the capsule, sometimes it may happen. So removal should be as much as possible safely without doing the maximum harm. And invariably almost all cases craniopharyngeal may need radiotherapy whatsoever in various forms. So in this case, this is good that everything is out, but you are saying patient having a lifelong morbidity. Maybe that morbidity before the surgery also, I think. Maybe hypothyroid or some other hypocortisol injury maybe. So anyway, it's a good, and keep going on. My blessing is there. Thank you.
Thank you, sir.
One of my beloved students. Lots of students are sitting here. He is one of my good students. Thank you.
Thank you.
Somebody want to ask any question or something? It's nothing in there then.
Thank you.
Request the team to kindly give the token of appreciation. For the next session, I would like to request Dr. B.K. Bashir sir to kindly be seated and Dr. Bernard Lingdo to chair this session on our experience with IONM, that is intraoperative neuro monitoring, which will be presented by Dr. Rajesh Kumar Borwa. Welcome you on stage, sir.
Good evening, teachers, colleagues, and friends. Thank you, Swami, for giving me an opportunity. Today, I'm going to say something about our experience with IONM that we have started recently. Coming to the first thing is, what is the need of an intraoperative neurophysiological monitoring? It is usually the limitation to clinically assess the nervous function during surgery that has led to the development of IONM. It helps in localization of the tumor, the orientation, the verification of the approach, because the tumor may usually displace the normal anatomy and the landmarks. And also prior surgery may result in scar formation. It's also used in verification by providing the warning for mechanical insults that can occur with stress, compression, and direct contact, as also temperature that may be present due to the use of byproducts. The stimulation provides the proof of nerve function and a possible prognostic value. Now coming to the history, Hans Berger was the first to report EEG tracings from human brains. The first issue of intraoperative EEG was done by Forster and Elternberger in 1935, and in the late 1930s through the 50s, Herbert, Jesper and Penfield further developed this technique. They also perform careful mapping of the cortical function by direct electrical stimulation. Now what does IONM do? It provides a real-time control loop between the surgeon and the patient. This loop provides a dynamic assessment in real time of the effects of the surgical manipulations on the structural functions, the relationship of the patient's nervous system, and facilitate the surgeon's decision making. It requires both a rapid and multiple simultaneous measurement of CNS function. It is done in real time. And this combination allows a close and dynamic correlation with operative manipulations. The nerve selected depends on the tumor location, the size of the tumor, the site of operation, prior deficit of the patient, as well as the surgical approach. Usually, a subdermal electrical needle electrodes are used that are usually placed in the bulky muscles near the tendons. Some nerves which are purely sensory are usually monitored by evoked potentials. What happens is that when the neuronic distresses caused by the irritation of the nerves causes the muscles to contract, and these are amplified and recorded. The irritations that can occur during the surgery may be due to stress, the compression that I said in the temperature. Nerve responds to such stimulus by causing a contraction of the corresponding muscle. It is most commonly used in the cerebral frontal angle tumors. The olfactory is a purely sensory and there is no monitoring this nerve. The most commonly used is the vestibulocochlear nerve tumor. The oculomotor nerves, the third, fourth, and sixth, can also be examined by this technique. However, application of the needle in the ocular muscles requires expertise, and this requires a team. The 11th cranial nerve, the spinal accessory, is a bulky muscle nerve, and it is usually located with typically strong, high amplitude response when it is stimulated. The 12th nerve can be stimulated by placing the electrodes in the lower lateral portion of the tongue. The 5th cranial nerve has a sensory and a motor fiber with 3 main divisions. Its key function is to move the muscles of chewing, and only the motor component can be monitored. The masseter is large, easily identified, and electrodes are placed in the belly of the muscle. These are the branches of the facial nerve supplying the face. And now, application of the facial nerve monitoring can be both in intratemporal facial nerve decompression, in mastectomy, tympanoplasty, cochlear implant, translabyrinthine approach, and labyrinthectomy. And facial nerve is the nerve which is affected by the intracranial surgery, in bony injury of the mastoid also. And intracranial tumor is resection, microvascular decompression, vestibular nerve suction. Now, facial nerve monitoring can be applied. The cranial nerve 9 is the prosopharynx, is the only motor portion of the nerve with the exception swallowing. Needle electrodes are placed with forceps in the palate, and it is usually difficult to assess and obstructed by the endotracheal tube. The vagus nerve can be assessed. The firing can be assessed by the specialist tube, endotracheal tube, which has a built-in electrode wrist. The senses, there is a light, red and blue light, that record the vocal cord movement. The imaging stimulation, the surgeons usually stimulate, and that needs to be localized and to localize and to identify the nerve tissue. The auditory feedback is the key. The speaker relays the EMG sound to the surgeon, and the main is the monitoring stuff that provides the verbal confirmation and information that the nerve is responding. The probes that are usually used are bipolar and monopolar. The bipolar has a greater spatial selectivity, and monopolar are used to search the nerve within the surgical field. These are the probes. Ironing for the CP ankle tumor. In our experience, we have tried for this CP ankle tumors and brachial plexus tumors, around 10 CP ankle tumor and 3 brachial plexus tumors. Usually, we get tumor very large, more than 4 centimeters, are mostly those. And the facial nerve are usually splayed out over the tumor, and it is very helpful in those. Now, the pathology of the CP ankle system is primarily that of the nervous and vascular structures. Roton is divided into 3 chambers, the upper, middle, and the lower, depending on the placement of the nerves, and the 3 supracerebral artery, the ica, and the pica. The incidence of the facial nerve paralysis following CP ankle tumor was 30%, which is very high. And prior to that, patient also have a hearing loss on that side. With advances in imaging, microsurgery, INM, the rest has improved steadily. Similar findings can be also seen in case with BIP, but the tumors should be usually less than 2.5 centimeter in diameter. And the timing of neural injury in surgeries of CP ankle is usually identified by dose, and this is the most important during the surgery. The injury can occur due to underlying pathology that has necessitated surgery, or it can occur during the operation itself. This can be mechanical, thermal, or schema to the neural tissues during retraction. The direct electrical stimulation helps to identify and distinguish the 5th and the 7th nerve and creates a map for this nerve in relation to the tumor. A monopolar stimulation is generally used for the monitoring and mapping on the surface. Then we use the bipolar electrode if needed to evaluate whether the functions are intact or not. A neurotonic discharge, if it is sustained, usually indicate that there is a nerve of risk of damage by thermal energy, and in this situation that we can use the cautery. In case of surgery in the CP ankle, only high quality bipolar electrode cauteries should be used, as there is a high risk of injury with monopolar electrode cautery, which we never use. Once there is complete injury of the facial nerve, they no longer produce neurotonic discharges are manipulated. However, the triggered EMG responses of the distal end of axon nerve is electrically possible. Therefore, prior to beginning of the debulking, the tumor should be probed, the mapping should be done by using a monopolar stimulator. The techniques of monitoring, they are the brainstem evok potential, the EMG monitoring, the sensory evok potential monitoring, the interpretive use of EMG recording consists of continuous monitoring and spontaneous motor unit potentials, and standard EMG settings of sensitivity are used for canal setting. Sensitivities of 50 to 200 microvolt per division, filters to 20 to 20,000 Hz, and time window is 5 to 10 milliseconds. The area of interest is the neurotonic discharges during the intraoperative setting. They are the high frequency EMG bursts or trains. Train of 4 that we say, which that may be continuous and occurs in response to mechanical stimulations. Things to be differentiated are the movement artifact, activity to the light anesthetic level, and electrolyte artifacts. These discharges last usually 1 to 2 seconds, and the various motor unit potential have a duration of less than 200 milliseconds. Their appearance in a single cranial nerve may indicate the nerve irritation and allow feedback to the surgeon about the presence of the nerve surgical instrument being used. Subtransaction of the nerve is less likely to give any discharges. It is always the INN team that which is who are the mainstay of the surgery, and it is they who should confirm with the surgeon if any additional monitoring may be required or if he has touched on any vital structure. or if any damage is underway, if he proceeds any further. When the exposure is complete, the surgeon usually requires the harmonic stimulator that produces a triggered EMG program for the monitoring of the CMAPs. However, before the surgery, a baseline BAEP and the median nerve SSP should be obtained, so that it can be compared in the pre-op and post-op to make certain that they are similar. Prior to stimulation of the nerve of interest, a control nerve should be stimulated to determine the threshold of stimulation for a normal nerve. Once it is determined, then 0.5 mA increment is used to search for the nerves or the roots. The typical intensity is that the healthy nerve response is 0.5 milliampere or less. However, there is a differentiating point. That the stimulation by trigeminal nerve give rise to CMAP at a latency of 2 to 3 milliseconds, and the facial nerve give a latency of 5 milliseconds. This is the CP angle with the electrodes placed at the bulky muscles that comprise the masseter, orbicularis, the tongue. We have placed in the hand, that is the adductors, pollicis, pollis. It can be placed in the biceps. We have the cathode and the anode 9 cortical electrodes. We have with the neutralizing neutral point also. Here I am going to see the CP angle and the brachial plexus tumor that we have done, that we are still continuing, and the discharges that they usually show before finishing the. These are for the intergroup 7 nerve monitoring. Here's the helicity in the babies. We are using a Medtronic Nematives system. This is a train of 4, which says that we are near to the nerve. This is the stimulation, the contraction of the muscles, the stimulation of the tumor and of the brachial plexus. The response is shown down the monitor. What we have found is that at least we do not have enough post-op increase in the deficit of the muscles power by using IONM. Earlier, there is an increased chance of the power, the facial nerve power, it usually deteriorate or reduce. There is a paralysis or neuropraxia of the lower cranial nerve also. Thank you.
Thank you, Dr. Rajesh. Lovely presentation, and it's nice to see that it started in GMCH. The lecture is open for questions. Anybody like to ask questions? What about lumbosacral IOL?
Lumbosacral?
Yes, have you done?
So we have started of this now. Because it requires a large thing. And it is very constricted in our part. So we are using only the motor evoked potential and quantity meter surgery.
So when you started operating CP angles with your monitoring, has it reduced the number of, has it reduced the debulking of the tumor? Are you leaving back tumor?
Yes, sir. We could just differentiate the nerve with we retract it, we dissect it from the tumor, and we used to keep it as such and remove the tumor. With the endoscope that we have, we can go deep inside and clear it.
This is just a comment now. Actually, now we just heard a lecture about litigation that is happening now with the medical fraternity, and the consumer is there. So very soon, maybe in another 10 years, I think neuromonitoring will be a mandatory for all these types of surgeries, CPI or lumbosacral, cervical surgeries. No? So I think neurosurgeons should start getting used to this, even though neurosurgeon with good skills may not require this, as you have a lot of false positive responses. So I think this is the theme of the future. Thank you.
He is one of the member of my team that we have started very in small number, but this is how it's quite helpful in two sense. Surgery time may be a bit slightly longer time. If you monitor these things, there is some extra time. But even then, patient safety is quite high. Patient safety means patient safety for preserving the important kidney nerve. That is quite high. And everybody noticed that after doing the surgery, if patient does not have facial nerve problem earlier the surgery, post-operative developed that paralysis of the one side of the face, there is a horrible distance. And sometimes patient cannot accept also. And is a once it is happened, full-time paralysis, then it is a lifelong problem. So if you preserve these things, that is one wonderful things. And I advise Rajesh for the different tumors, particularly jugular foramen tumor, lower cranial nerve involvement, and one important, he's mentioned this thing, spinal somatosensory potential for the spinal cases. That is all quite helpful, and that can be also incorporated in due time. One big team is essential. One expert OT technician, particularly for this monitoring, this is important, and he is quite helpful. For a single surgeon, without any trained staff, sometimes many false positive results or false positive, false negative, both things can happen. And then the utility of this, all the monitoring is not full functioning. Thank you. Dr. Naba will say something.
That's a very nice presentation. Actually, we see in case of segmental tumors, acoustic sternoma, when the size is more than 4 centimeter, post-operatively, it's written in all books, and we find also we get facial nerve pulsing. So after using IONM, we don't have much experience as we are not using it right now. So what is the change in result? Like in larger tumor, after using IONM and prior to using IONM, what is your experience?
Prior to using IONM, when we dissect the tumor, usually we remove the facial nerve also. Mostly post-op, the nerve is almost paralyzed. It's up to grade 4 it goes. And with IONM, it remains the same.
What about whether you get, because if the tumor is more than 4 centimeter, ideally, whatever we do, we get some grade of, whether higher grade or lower grade of facial palsy. So after using the IONM, what is happening? That's what I wonder.
It has remained same. Earlier what happened is just pre-op, if it is higher, in grade 3, and post-op it is usually grade 4. Now it has remained same, and we use, since it has been splayed out, the tumor, the 8th nerve or 5th nerve, we can just dissect it from the tumor and we can try. We are still learning, and we have only done 10 cases.
Thank you.
Thank you, Dr. Rajesh. Nice presentations. So I just want to give some comments. So I have been using the intraoperative neuromonitoring since 2018. So I have started my surgery in Johar Medical College with intraoperative neurosurgical monitoring. So what we have faced the problem, the first problem is the anesthesiologist. Because most of the anesthesiologists in Assam, they are not experienced enough, or they are not acquainted with is an intraoperative monitoring, because total intravenous anesthesia activa or without relaxation, it is very difficult. And another thing is the team training and technology. So there is no coordination between the team training and technology. Most of the technology is newer for us, usually for the technical assistant and the team. So interpretation of the findings is very difficult interpretably. There are certain confounding factors. Number one is the hypotension, blood loss, use of the electric modalities, even the electric ECG leads also. This also gives some confounding factors and very difficult to reinterpret. So another problem is only the stimulation and getting the graph is not enough. Sometimes after cutting the facial nerve also, what I have faced, so for few hours it may give the stimulation falsely. So in those cases, so one of the important things is that see the visually the contraction of the muscle of the facial musculature during the monitoring is important. So if the neurophysiologist is available with you, which is not available in our places, then anesthesiologist should monitor the facial muscle contraction during the procedures. And it is very helpful in the excising the spinal tumor, especially in the quadricular regions. So when you are excising the filium terminally ependymoma, when it is adhering to the different roots, then it is very easy to differentiate whether you have to excise completely or you will leave behind some part of the tumor. Because in spinal tumor, one difficulty is that using the CUSA, ultrasonic aspirator. Because using ultrasonic aspirator, sometimes it may also give injury to the nerve roots. So in those cases, only sharp dissection is the only solution. And in those cases, this nerve monitoring may give the benefit. So our experience is not so good, not high. I have operated around 50 to 60 cases with nerve monitoring, but with good results. I can confidently say the facial nerve initial period when I started, then I had some misadventure with the facial nerve injury, 2-3 cases. Then after that, there is no facial nerve injury with the nerve monitoring. And it is very easy to preserve the lower cranial nerves. At least patients' chances of getting tracheostomy is less with the nerve monitoring. Thank you.
I would like to request Dr. Duldeka sir to kindly come forward and felicitate Dr. Rajesh Borwa sir. Thank you, sir. Our next session is it is a discussion on a series of few interesting neuro cases which will be presented by Dr. Satish Bawri. I would like to request, I would like to request again Dr. B.K. Bushya sir and Dr. Baya to kindly chair the session. Welcoming Dr. Satish Bawri sir on stage.
Good evening, sir, my seniors. And my friends. Today, actually, I didn't talk on any specific topic, but I would like to share some of the MRI pictures and the history of some of the patients, which are often needed in our day-to-day practice. Now, why, when, and we should do all these things. We do our education by seeing the patient, and I think we learn from the patient also. So it's important for the patient benefit to enhance our knowledge and for medical issues. So my first case a 61-year female. She was admitted with mild headache and ataxia for 2 days. Initially, urinary imaging were normal, but on the second day, she developed difficulty in swallowing and SpO2 dropped, and we repeated the neuroimaging. These were few of the pictures. So, now in these findings, we have so initially now these are the lesions we find in the cervicomedullary junction. These are very atypical functions, lesions. Maybe many of our radiologist friends have not seen these. So these lesions are incomplete lesions, although looks like circular, but that's incomplete. We had a discussion with our radiology department. We started steroid, but the patient doesn't improve, deteriorates. We did CSF, every other possibility is ruled out. And these lesions, we searched the articles and very typical of large vessel vasculitis, and this patient has improved with IVH. Now the patient is on MMF, very nice. Second, this patient shifted after 5 to 7 days from Silchar. Is in a hypertensive, IgA nephropathy on low dose steroid. He came with facial weakness, quadriparesis, developed aspiration pneumonia, shifted to hospital. At that moment, the patient was conscious but had difficulty in talking. The quadriparesis of low motor neuron type, and we evaluate this patient. Since it's a low motor neuron type of quadriparesis with a facial weakness, so we thought of AIDP. Second came to the myasthenia gravis, but on the second day, the patient again had some altered sensorium. So before doing the neostigmine test, since the patient was on steroid, hypertensive, so we did a nerve conduction, but that was not very much suggestive of AIDP. We did an MRI. This MRI is not good, but more concurrent lesions, which are very typical of MS. This patient remained on tracheostomy for around 5 months. Intubation means the bed goes on ventilator for thrice, and now he is good, working on time and health. Third patient, 26-year female, right-sided blurring of vision for 3 days, nothing else. She came, the first thing, obviously this is a demyelinating lesion. We worked out, and these were the pictures in the eye. Again this, and the spine. So this patient fit the criteria for McDonald's criteria, and we level it as our first episode of MS. Now why this? Why I put for discussion is that our next question was, sir, I'm planning for a baby, so which will be a good medicine for me, whether there is a chances of relapse. Unfortunately, the patient refuses CSF, so we can't go for OCBs, but other criteria and as per clinical criteria, all match. So few of the demyelination characters are, this is an incomplete ring enhancement, this mixed T2 iso and number intensities, absence of mass effect, lumbar puncture should not be performed if there is a risk of high, any severe cerebral edema, brain biopsy is not needed. Although the first line of treatment we usually go for methylprednisolone, but yes, plasma exchange and other modalities are there. Now the fourth case, this patient admitted recently with a headache for 2 months, not responding to painkillers, no history of trauma, this patient was initially evaluated, and he has cerebral venous thrombosis with fungal sinusitis on antifungal for 2 months. He came, had empyema along with hemorrhage, and there is a long infarct. The question arises, what happens if what led to CVD in this patient? Since the patient developed subdural hemorrhage, hematoma, along with the empyema, should we go for anticoagulation? Does the fungal sinusitis causes CVD? So these were few questions which were left unanswered. So these were the operative line which Dr. Shameen will let know. Thank you.
So it is good. All cases are typical cases in their own merits, and through these typical cases or rare cases, we have some great learning. The topic is open for the house. If somebody want to comment or ask some question, they can do that.
Urologist in the hall. That is the reason there is no comments or question. But approach to a white matter disease is a very big thing. Although the neuroimaging has started adding a lot more of sequences that can help us. In the first case of the medulla, in that case, even MRS would have been difficult because usually MR spectroscopy is a bit difficult in the posterior aspect. But I think if we did, diffuse tensor imaging or further imaging.
Yeah, we did everything, and that's the only single lesion.
Okay.
Literally, we have to search for the lesions and all those things, incomplete ring. Such means the characters of the lesion in the appropriate group. What this is very difficult to get.
Yeah, because
so
even
many times the relative is, can it be a tubercular? See, it's announcing incomplete ring. So can it be a tubercular? So again the question comes, we give a high dose steroids, immunosuppressants, can the tubercular flare up? So no, but again we had a long discussion on that, and we go on for
Yes. So finally the diagnosis was vasculitis and an infarct, right?
Yeah.
And it was autoimmune only?
Yeah.
Okay. And then the second case of quadriparesis and facial palsy, right? So you found any lesion in the pontomedullary junction or in the brainstem?
There's a lesion in the hemisphere, all over the white matters. There's corresponds letter to the... Actually, we thought of myasthenia gravis because the patient had the extraocular movement, also the impact.
Okay,
So the next probable diagnosis which came to our mind is, can it be a myasthenia gravis? Acute crisis goes into the aspiration pneumonia. So, but yes, since he developed encephalopathy, so before going for the neostickling test, we tried for an MR, and we did, and we got this. Then we going for the steroids and other things, and the patient improves. But yes, the problem now is okay on dimethyl.
And the last case after the surgical intervention, could you come to a conclusion?
No.
That subdural empyema or subdural hemorrhage?
No, empyema is, this sterile. There is no fungal hyphae. The cultures are sent that those were sterile, and the question remains unanswered. What led to cerebral venous thrombosis? Because the patient earlier MRI has said pachymeningitis, and the patient is on antifungal for last 2 months.
Yes. Empyema can develop in immunocompromised patient for any reasons, for maybe some drugs and all. And the very distant infective lesion also may cause that intracranial infection in the form of empyema. And empyema subsequently causes the vasculitis. Everybody knows this. Vasculitis causes the infarction. Maybe that last case, maybe that yes. And in the first case, as she mentioned, that I thought it was a granuloma.
Yes.
First.
Yes, sir. That comes to that
granuloma in the form of maybe tuberculum, maybe. So it was my first impression, but subsequently it is vascular lesions and it's but quite round.
Quite round, but still incomplete. That is a typical finding of.
But one thing I know, it was given some contrast.
Yes, sir.
It was contrast picture.
Analysis on contrast.
Okay. Then ultimately you have achieved some diagnosis. Okay. As she says that there is no neurologist here, my impression is that all neurosurgeons basically neurologists. Basic neurologist should know all neurosurgeons is basically a neurologist with some surgical skill. That is the thing. When I was in resident level in PGI Chandigarh, I will have always a hungry for some patients. Any patient come to I used to see. Any patients. Then my senior resident under whom I trained, I first year, somebody in the third year, he said, hey, don't see this patient. Headache is a neurology problem. Let them say the headache, any headache, it will go to neurology. If something happens, something comes, then it will come. Don't see this thing. Then I usually send the patient to the headache patient to the neurology. I was very great opportunity. I was happy and privileged that I was a resident of Dr. K. Bhimasai. K. Bhimasai was, this K. Bhimasai worked in GMC also, and in CMC Vellore, he was a long time in Georgia. It's a very respectable and the drawing of neurosurgery in our country. I have some opportunity to become a resident under him. He was the finest neurologist. He is one of the finest neurologists ever have in this world. I can say like this. In this India, there is comparison with his neurological knowledge. So when we work under him, everything he passed clinically and neurologically he described everything. So I think all neurosurgeons should have a good neurological knowledge, then he will be a good neurosurgeon. Otherwise, it will be 100% mechanical. Thank you.
I would like to request Dr. Alfred sir to kindly felicitate Dr. Satish Bhavri.
Actually, he's a neurologist over here.
Yes. So coming to the end of today's Neuro update, I would like to invite Dr. Shamim Ahmed sir for the last session of the day, to speak on preventive neurosurgery, a vital focus, reducing risk and improving outcomes. To chair this session again, I would like to request Dr. V.K. Bosha sir to kindly be seated, and I would like to request Dr. Deva Borgohai to kindly join V.K. Bosha sir in chairing the session.
Good evening, Inspector Sir, my dear friends and seniors. Coming to the end of our today's topic, we have talked a lot of things about the illness, starting from the minimally invasive neurosurgery to high-end neurological diagnosis, and so many things are discussed. So that's why I'm choosing a topic which is a little bit offbeat. A lot of illness has been talked. Let us talk a little bit of wellness. So,
in my specialty as a neurosurgeon, what are the wellness things we can do or we can try to practice for ourselves and for my patients also. So what is a preventive neurosurgery? So this is a proactive approach to neurosurgical care that aims to prevent the neurological disease and its complications. And this way you can minimize the risk of developing those diseases to further, or you can prevent to some level. So the objective of this study, and at the end also I will share my experience with these preventive measures. So what are the higher importance, why we need to discuss these things, and how to explore the future opportunities. And why it is important? Because these are the three major things in an overall neuroscience. Stroke, a major cause of disability worldwide. Traumatic brain injuries, there are spine injuries. This is a growing global concern. And lastly, spinal disorder, like everybody having a neck pain, back pain. So are these related to our lifestyle related, not only the diseases? So overall the society is developing a high impact. So citing some literature, as you all know, everybody as a general physician will know that folic acid and the neurological defect. Unfortunately, our country still have a lot of spinal dysplasia because we are not supplementing our mothers with folic acid. We should supplement more, even in countries like Brazil and the American countries where folic acid supplementation in salt is mandatory. Like we get Tata salt, iodized salt, they get folic acid supplemented salt in their countries. But unfortunately, we don't have in our countries. And you go to a little bit advanced, it is not folic acid, it is the tetrahydrofolate, it's more activated form. Directly you can give and get the preventive benefits. So one is the neurological defect. The other thing is the folic acid supplementation can really prevent stroke as an independent stroke preventive agent. If you take it regularly, except some contraindication, it can help in community cases. The burden of stroke can be reduced. So fortifications, definitely one fortification is the folic acid fortified salts, not available in the country, but we can think of one study was done recently in Andhra Pradesh. They tried to give folic acid in their salt and they found a significant change in the outcome in the society. So this is a small effort, still not published. It's done by one of our friends from Deepu Medical College. What they are trying to do, fortify their salt, tea. After doing this community program, they fortify their tea with little bit of folic acid. And it's really giving some good effect. Results are yet to be published. Probably by end of this year we'll get the official results. Coming little bit of high-end things like do genetic screening we should do to find the neurological disorders. A lot of ethical issues are there. Overdoing is bad, but in developed countries they routinely do it. Just have buccal mucosal sampling and to find out any correlation with the developing some neurological conditions. But most importantly, it is those having a family history. But again, a lot of ethical issues are there. Should we do it routinely? And the second issue is like country like us, is it really cost effective? So one studies this shows this association between the apolipoprotein E polymorphism and Alzheimer's disease. So should we do it? In families having a high dementia patients, Alzheimer's patient, we should do it. But routinely doing ethically not possible, when a cost-wise a poor country like not possible. So consensus is yet to develop. Another aspect beyond this folic acid and genetic study, the telemedicine. This is really evolved in the last few years, especially at the post-COVID era, when we are taking the advantage of telemedicine. As a neurological doctors, we get the scan immediately. The patient sends their videos and the scan, and you can have a presumptive idea of what is the thing going on. You can talk to your verified doctors or the patient what can be done at that immediate point. So it's really helpful, something like a WhatsApp. Just send this patient video and scan finding. So beyond that, advancing technologies like artificial intelligence is moving up. So one the app, something like Apple has developed, is CIU. There are a lot of apps. You can just put your things in the app and it gives a presumptive idea what is their probable diagnosis. It really helps us to give a question. Even a ChatGPT like app, you put some things and it gives a presumptive idea what can be possible options. Patient education as a healthcare worker is all our responsibility to educate our patients. Variety of things. What are the markers of stroke? What are the possibility of a seizure? How to prevent those things? So awareness really helps in a community level. So as a healthcare worker, we should try to do whatever possible. Another importance is the brain hemorrhage. It can be traumatic, it can be the stroke hemorrhage. We should all try to prevent that. This is the basic thing everybody knows. Good sugar control, regular exercise, lifestyle modifications. should try to do. So, to start the literatures, is it a cost-effective analysis? Is it possible to do aneurysm? It's not possible to do all patients doing angiography. Ethically, it's not possible. But if you can afford it, or in high suspicious patient, we should do routine angiographic study. I think on this, you can pick up some unruptured aneurysms. Again, awareness. You know there is a stroke, but by the time you diagnose it, it becomes late because time is brief. So if you are not bringing the patient on time, the interventions may not be possible. So time is important, like a thrombolysis they do in a neurologist. You should come preferably within 4.5 to 5 hours. If it is late, you can diagnose, but the outcome is different, treatment is basically nothing. This is the wide spectrum of the thing that back pain and neck pain is one of the commonest cause why a patient attend to any doctor for back pain. Most of them are related to lifestyle related issues only. So preventive aspects starting from a good mechanical postures, adopt healthy lifestyle practices, regular exercises, manage your stress. It is also an important thing. So starting from ergonomics, keeping yourself active, sitting properly, taking regular breaks, devices, pick your neck and back straights, and care. The lifting heavy objects, the sitting, you should not be in a standing. These are small tips, but it's really work. And at the end, a regular exercise is mandatory. Coming to little bit of the injury, is very important burden for the whole society, even for in our place also is very high. So there are multiple factors. We should try to solve this factor, not at the individual level, community level should come, starting from the poor road to legislation to the things, implementation of laws, like a speedometer, wearing helmets, small tips, but at community level, if you can develop, it can really reduce the burden of this kind of unfortunate events. There is one slogan that is recently this FM, they have started, the road safety hero, where they are actually trying to find out who are the persons who are following the road safety norms, like wearing a helmet or wearing a seat belt, when taking the speed limits. So they should be actually promoted actually, rather than showing something that who is drunken and driving. You should promote who is maintaining the positive things. So these are the same things, following the traffic rules and wearing helmets, seat belts, things. Healthy lifestyle we should all should follow. So role of wellness is a holistic approach. It's not one thing. It's lifestyle monitoring, and the sleep, the nutrition. These are three triangles where I want to focus basically. So you should have a good nutritional backup, healthy food like a omega-3 based and antioxidant food diet, regular exercise, very, very important. Not only physical, mental health is also related. And ultimately sleep, where we compromise. More to success, we do more work, but it's bad. We should sleep adequately. So we should nurture our sleep and get to in a physiological time. So nutrition, we know it is a combination of things. There should be an adequate amount of fatty acid also along with the other things. Is one imaging that's showing how sleep is important. You can see the hippocampal sclerosis. If you sleep less, the brain becomes atrophy, whereas if you sleep adequately, the hippocampus is full. You can show a functional imaging, how the brain swell up. So it is said that walking and sleeping, it not only move your body, it basically expand your mind also. So mind and body post synchronization. Walking itself is a very, very important good prognostic marker for somebody's survival. So it's one of the meta-analysis that shows by walking a good number, ideally it is 10,000 steps per day, it can overall reduce the mortality of any disease, not only neurological. These are some lifestyles what we have tried to find, like the Japanese lifestyle is one of the things we guessed, not only because of their diet and sleep, but also for the exercise. They believe in a lot of walking, the interval walking. Take 3 cycles of walk in between your walks. Stress management, again these practices, if you reduce your stress burden by your adaptive ways, you can actually improve your brain plasticity. So integrated approach, so there should be not only the patient preventive, those who have suffered something also, we can give them an integrated rehabilitation approach to make their damages further reduced. So the collaborative team care approaches come not only in the preventive but also in therapeutic, especially in the follow-up patient. Ikigai is another Japanese way of living, how you balance your life. So you should try to keep a balance between our social life, family life, and the professional life, and should give time to yourself. Tashi Devek, again, one stay way of Tibetan lifestyle. All this focus to the wellness basically. So it's a balancing of our lifestyles. So what is the recommendations? So the diet, exercise, and sleep. You should just modulate these 3.
and also some supplement at time like folic acid and omega probably some available. Data-driven decision is basically on you, how you get your data, how your patient are doing, and can make a better decision for your community users. Little bit of my subject where prophylactic neurosurgery is definitely debatable, but there is some role of prophylactic surgery in an uncontrolled intractable epilepsy. In syndromic patient, probably there is some role. In syndromic patient, like monocle window, before it transforms to a malignant disease, you can go for surgeries, although they are less symptomatic. Large unruptured aneurysm, you should go for treatment. AVN, large aneurysm going to rupture, you should treat it. Although they are not presented, but you should treat them, otherwise they will go for massive complications. Even in spinal cord, like a cross-deferring of cord should be detected before they go for permanent disabilities. So future is with this AI and the newer technology that their collaborative efforts are coming up. And the challenges are basically a lot, but we have to overcome those, starting from limited access to high-end diagnostic tests, cost factors, social factors are there. This is a little bit small effort, but we have designed these packages in my places, how I integrated some of the investigations and tried to do some health checkups. And I found almost about 33,000 of the health checkups are done in the last 5 years. Of these, almost 8,000 plus were done from my side. And they got diagnosed some of the asymptomatic tumors, the spine disease, aneurysm, not insignificant. They're totally asymptomatic. Probably there is some role of checking and then treating them accordingly. So take-home message is that advances in preventive neurosurgery are crucial for enhancing the patient outcomes, and by integrating the technology, education, and our own efforts, we can definitely make a change. So continuous innovation and adaptations are essential. And finally, this is the 8 dimensions of wellness. We should try to balance ourselves around this. Thank you.
Dr. Sami, yeah, very good. The new insight to the subject. So we are discussing about the treatment of the disease, but he's speaking of the not to have disease.
Yes.
Yeah. Before disease comes, it should be prevented. That's a good idea. And anybody want to have some ideas on some comment? This subject is open. This is one type of quite not new. Prevention of diseases, everybody knows, but disease prevention for neurological problem is a relatively new concept, and many countries, European countries, American countries, they have already started these things. We all know if particular neurological and neurosurgical something happens, it is costly, number one, very costly for treatment. And after costly treatment also, it is not guaranteed that you will be 100% okay, that before surgery or before disease, you was like this. It may not be like this. Yes. After surgery, after treatment, full treatment, costly treatment, even then you may not be this thing. But one thing, this is one thing. Another thing is that whatever prevention you take, there is some disease that it will happen. It will happen. Because with prevention, all the things cannot be prevented, but many things can be prevented. Whichever related to lifestyle diseases, that 95% cases can be prevented. Yes. But there is some cases, say, totally asymptomatic glioma. When glioma comes sometimes, already it is a stage 4, it is very big. But before that, his symptoms may be hardly for 3 days or maximum 1 month. So, in that case also, if we have some preventive, some protocol in this our country, say every more than 40 years, every yearly one imaging is mandatory. Like that, 40 years plus ladies, pap smear in a year is a mandatory. Yes. Whatever somebody do or don't do, their choice. But if it is something like that, then many things can be prevented. Yes. This is a good part. Thank you. And with this concept, we should also take a leader as a neurologist or neurosurgeon. We should take as a leading role for the society, for the community, to make some awareness. To make some awareness that we should come or at least for counseling, some preventive treatment, as we are doing the blood sugar, etc., master health checkup, like this. So master health checkup for other disease, maximum focus on the cardiology. Yes. No, cardiologists are very expert. They are very smart actually, cardiologists. It's not, they also no cardiology, no? They will kill me. They are quite smart. They are dealing with one organ, one balloon only, pump like thing, no? But they are quite smart. All this master health checkup, maximum awareness for the health in relation to the cardiology. You just see everything in the paper, in the newspaper, in the air, everything is focused to the cardiological problem, not the neurological problem. But wherever is dying maximum thing, people are the stroke. Imagine stroke and other some neurosurgical or neurological diseases. But somehow we are lacking to make the people awareness about these things. We are dealing with the most complex organ, but even we are not number one for the community publicity. We are maybe number 2 or number 3. So I encourage all these leaders sitting here to take some leadership. It should come up over the cardiology. Right? Thank you.
Thank you, sir.
Thank you, Shamim sir, and Dr. B.K. Bushra sir and Dr. Deva Bormahai sir for chairing the session. I would like to request Dr. Mayur Goswami sir to kindly felicitate Dr. Shamim Ahmed. So we have almost come to an end of this session. I would like to invite now Mr. Manav Chanda from Sun Pharma, who is our academic partner, to kindly give away the vote of thanks.
Good evening, everyone. So we are at the fag end of Neuro Update 2025, organized by Apollo Hospital, Guwahati. So I feel privileged enough that I have been nominated to give the vote of thanks. So at first, a special vote of thanks to Dr. Shamim Ahmed sir, Dr. Satish Gauri sir, and Dr. Deep Datta sir to organize such an academic intensive CME and did all the follow-up. I would like to give my vote of thanks to entire team Apollo Hospital Guwahati, who did all the back-end follow-up and the job, which has resulted into such a flawless CME, where we got almost 95 plus august presence of neurologist and neurosurgeon of entire Northeast. A very special vote of thanks to all the attendees who has attended and all the faculties and chairpersons who has given such a nice deliberation of their respective topics. A special vote of thanks to Hotel Vivanta, who has did all the jobs, hospitalities, which is really flawless. And at the last, I will give a special thanks to Shamim sir to give us an opportunity to be an academic partner of such an event. And in future, I would like to request sir to give us more opportunities so that as an industry partner, we will always be with you for such an academic thing. So thank you once again to all of you, and we will be breaking for our dinner, and I think there is a cultural event also. So cultural event followed by dinner. Thank you.
Thank you, Mr. Manav Chanda, for the vote of thanks. So thank you all, audience, for your patience, hearing and interactive participation throughout the sessions. So we have come to an end of this formal sessions. Now you can enjoy the dinner, which will be simultaneously the cultural night will be going on.